Okay. Good morning, everybody. This is Laura Freed, and it is, by my computer's clock, it is 9:04 a.m. So I'm going to call the July 23rd, 2020 PEB board meeting to order, and I will start by taking the roll. Linda Fox. Linda? Okay. Don Bailey.
Here.
Marcia Urban.
Here.
Jet Mitchell.
Here.
David Smith.
Here.
Tom Verducci.
Here.
Jennifer Krupp.
Here.
Once again, Linda, are you on? Okay. Well, we do have a quorum, and I'm sure that Vice Chair Fox will join us when she can. I wanted to pause here for a second and allow Member Mitchell to make an announcement. She wanted to say a few words to the board. Jet, it's up to you.
Well, thank you, Chair Freed. Jet Mitchell for the record. And for those that can see me on video, I am now completely bald. I am doing a new chemo that one of the side effects is hair loss. And because I don't wear wigs or hats or scarves, I'm very open about being bald. And I just wanted to let everybody know that up front. This is my third head shave. And the good news is that I'm still in treatment, but I don't believe that metastatic cancer or any chronic disease should be whispered about. So I just wanted to put it out there, have everybody get comfortable and let everyone know. And then we can move on to the important board business. So thank you for your support. Thank you, Chair Freed. And I'll be having a no hair day today. So.
I feel like I can speak for the whole board when we wish you the best in your course of treatment. And I think your bravery is really inspiring.
Thank you. And thank you all for your support. So just wanted to put it out there. I wanted everyone comfortable. I'm always happy to sidebar conversation about treatment and et cetera. I've been very vocal as a patient and patient advocate. So just wanted to put that out there and thank all of you for your support. So onward and upward.
Excellent. All right. So with that, we'll move to agenda item 2, which is public comment. There are 2 public comment periods. Depending on the amount of commenters we might have in the queue, I think I'm going to try and limit this to 4 minutes per person. And with that, I will turn it over to PEB staff.
Thank you, Madam Chair. I'm going to go ahead and share my screen here. And as Madam Chair said, this is the public comments portion of the meeting. So for those who are calling in during this period, I'm going to read off the last 3 digits of your phone number. When I announce those, you would be advised that your line is unmuted. You should hear an audible tone by Zoom saying that it's unmuted. And at that time, you can go ahead and proceed with your comments. So let me pull up the participants here. We do have quite a few numbers that have called in. So the first one that I have, area code starts with a 4, last 3 is 920. Your phone is unmuted. Okay, I think they're not saying anything. Next one I have, the line is 198. Your line is unmuted. Okay. I apologize. I got a message here that 198 that I just read off is actually Linda Fox. So let me go ahead and add her in here.
So, Mr. Carroll, while you're organizing the public comment, I'll just note for the record that Linda Fox is present at the meeting. So, thank you.
You're welcome. Okay. Next line that I have is 4029. Your line's unmuted. Okay, and next one I have is 193. Your line is unmuted. Next one is 511. Your line is unmuted. Okay, next one I have is 688. Your line is unmuted. Okay, 277. Your line is unmuted. Okay. 338, excuse me, is now unmuted.
Good morning, Chair Freed, members of the board. Can you hear me okay? This is Priscilla Maloney with the AFSCME retirees.
Yes, we can hear you.
Thank you. I will save my public comment till the end of the meeting because I believe we're going to go through some rather somewhat complex and detailed things around agenda item 9. Well, 9 and 10 really, because the policy in 10 meets the budgetary concerns. They intersect in 9, as you know. So I will save my comments to the end. I just want to sort of register my presence in this meeting. Thank you very much. I'll mute myself now.
And the last one we have, I apologize, it looks like the list is jumping on me here. Last one I have is 404. You're now unmuted.
Yes, can you hear me?
Yes.
Hello?
Yes, we can.
Yes, good morning. Good morning, respected chair and committee members of the PEB board. My name is Kevin Ramp with AFSCME Local 4041, representing active state employees. We would like to be on the record as neutral on items 9 and 10, although we're really adamant about some of the budget changes. So we may look at opposing some things, but as of right now, we're neutral. In regards to item 9, we understand the need to bring plan design changes to build the budget for fiscal year 22 and 23 and adjust policies to create improvements within PEB on item number 10. However, we strongly feel that there's a lot of time to make improvements upon these policies and plan designs as our AFSCME members look forward to working with PEB and to ensure that, you know, we kind of vet all processes and policies even further than today, just to kind of push these through to create a budget. It's kind of early in the year. We normally look at these things in November through March, and again, we just want to know that the intent of today is really a concept design, as stated, and kind of highlight some of the things that we need to look at PEB come November through March. And we're excited to work with you guys as a union that represents state employees. The concerns that we really have is we have to ensure that we prevent any benefit losses or increases to future premiums. At the end of the day, that's what we're all looking at. However, we feel that jumping to, you know, things that they're not tried and true, we have serious concerns with. Ultimately, there's, you know, some new plan on the table. Members have been looking for stuff like that for many years, so we appreciate the opportunity to vet that even further. But again, we have to look at if today is just really building around a budget, or is this a solid policy plan going forward? And that's what we're concerned with. So we don't want nothing set in stone. We just want to make sure that you guys have a solid budget, allow the governor to make the various changes, legislators to kind of vet it, and then of course come back to the PEB board for possible changes. And we just ask you to continue to look at within to us and others to ensure that changes can be brought forward, and even potentially look at other plans possibly from other states. These are difficult times, and other states are doing really good things, and we just want to bring those forward if we need to, if this plan is not something that's going to be viable for the state of Nevada. As a board, we ask you to take into consideration that state employees look to you to protect their health insurance benefits. State employees consider health insurance
Mr.
benefits
Ramp?
as part of their compensation packages overall.
Mr. Ramp, would you wrap up your comments?
Yes, I will. As really, they're paid less than 30% from cities and counties, and they really have to have this package affordable. Anytime that state employees are cut, it's always on the backs of them. We were very grateful that AFSCME got to work with the legislators and the governor's office on this last furloughs, but they cannot afford benefit cuts or premium increases. With that being said, I appreciate your time, and I may have more for public comment at the end. Thank you.
Okay, and looks like we have one more, and the line ends in 837. You're now unmuted.
Thank you. Good morning. This is Kent Irvin, Kentervin, representing the Nevada Faculty Alliance, the independent statewide association of NSHE faculty. Regarding items 9 and 10, the plan design and policy changes, we very much appreciate the thought and work that has gone into taking a fresh look at the PEB plans and the rate structure. Thanks very much to the board members and staff involved in strategic planning. The board needs to approve the PEB agency budget request that must be submitted before September 1, and item 9 appears to be the only means for board input. We are alarmed by the 5% and 10% reduction proposals, which would make the already high out-of-pocket maximums catastrophic for employees with serious chronic conditions. PEB should calculate the base budget based on no change in benefits or plan design, and then provide only those reductions required to meet the governor's budget caps as negative enhancements. Without comparing the cost of maintaining current benefits, there's no way for either the governor or the legislature or advocates to gauge the true impact of the cuts. The future economic environment is so uncertain that planning only for cuts is misguided. If there's a vaccine by January with effective national implementation, the pent-up demand for tourism travel may well provide a positive outlook to the economic forum in May 2021. Of course, it could go the other way depending on politics out of our control. Nevertheless, it is prudent to plan for either scenario. Regarding the new low deductible plan, we appreciate the intent, but as presented, the deductible is not really low. To evaluate this plan structure, and this is an item that we have supported to consider, we request that staff provide estimates of how rates and premiums would vary for the three plans. Even guesses would help evaluate whether this structure is truly beneficial to participants. The board also needs to see what the low deductible plan would look like at a 0% flat budgeting level with a true low deductible in place of the missing current plan in agenda item 9. For the policy changes in item 10, we have the same request. With the explanations in the board packet, it is hard to understand how they would affect rates and premiums and overall budget. It's essential to bring back details in September, including mock-ups of the rate tables based on current year rates and best estimates for the new low deductible plan. That's the only way we can truly evaluate these new ideas. So thank you very much for your work, and we appreciate all that you do.
Madam Chair, we have two more.
All right.
853, your line is now unmuted.
Hello, can you hear me?
Yes, we can hear you.
This is, good morning. This is Doug Unger with the UNLV Benefits Advisory Committee and the UNLV Faculty Senate, also president of the NFA chapter at UNLV, representing UNLV faculty. I'd like to also speak to item number 9 on the agenda, and I had tried to write a reasoned public comment last night, but couldn't do it because I was thinking back over the 9 years of our advocacy and understanding that the most consistent point we've been making to the board is that deductibles are too high and out-of-pocket maximums are too high. I think about why I've got involved in health benefits advocacy in the first place, and it was really because I got to know the stories on our campus. The administrative assistant who lived in her car for 3 months because she didn't have enough money to pay the out-of-pocket maximum for very high medical costs. The UNLV photographer who walked around and worked with back injury for more than a year and a half in order to save up the out-of-pocket maximum in order to have his back surgery. And there are many, many stories like this, and especially stories of faculty who do not utilize the plan when the out-of-pocket maximum goes up too high because they can't feel that they afford it. And then their medical condition gets worse, and they end up costing the plan and everyone else even more money. I would like to support the NFA position that please look at these different options without changing the base benefits. Give us the news, what the premiums and everything else would look like before the budget cuts, and give us a chance also to advocate before the legislature and the governor not to reduce the state contribution to Nevada state employee health care. We believe that during a pandemic, we should not be punished by having our health care reduced. It's a retention problem for all state employees, and it's one of the most important factors in retaining and hiring competent state employees and competent faculty. Same thing with the policy on item agenda number 10. Please just give us in September a good idea of what the costs of evening out the tiers and the administrative cost changes are going to be. Thanks so much for being there. We really appreciate all the good work the board is doing. And a special shout out to Jet Mitchell. Please know you're in our thoughts and in our hearts. Thank you.
Okay, and the last one that we have, Madam Chair, the phone number is 121. Your line is now unmuted. That is all, Madam Chair.
Okay. The reminder to everybody listening that there is a second public comment period under agenda item 11. So if you didn't get into the queue or something went technically wrong, you have another shot. Okay, moving on to agenda item 3. I will throw it to Deputy Attorney General Mooneyhan.
Thank you, Madam Chair. This agenda item, of course, is for me to make a disclosure on behalf of the board members who are eligible for PEB benefits, which is everybody except Mr. Verducci. When PEB board members vote on matters affecting benefits for themselves or their family members, it may trigger the disclosure requirements under NRS 281A.420. I note that the law does not preclude the board members from voting on the items. Of course, most of the items on today's agenda are going to indirectly affect PEB benefits, but items number 9 regarding possible plan design changes for fiscal year 2022 and 2023, and item number 10 regarding recommended policy changes for the same plan year relate more directly to PEB benefits. So pursuant to NRS 281A.420, on behalf of the board members eligible for PEB benefits, I'm offering this disclosure that they will be voting on matters that may affect the benefits available to themselves or their family. I also invite any member who has anything additional to disclose to do so now. And thank you, Madam Chair.
Okay. Moving on to agenda item 4. Now, there are a lot of reports on this consent agenda. We've got minutes from the May 28th board meeting, budget and utilization reports under 4.2, and then we've got vendor reports under 4.3. So board members, you've had a chance to peruse these. Is there any thing that any board member wants to pull for further discussion? And then we can vote to accept everything that nobody wants to pull.
Madam Chair, Tom Verducci for the record.
Okay.
I'd like to pull 4.2.1,
Okay.
4.3.5, and 4.3.7.
4.3.5 and 4.3.7. Okay. All right, that sounds good. Do I have a motion to accept everything on the consent agenda items except 4.2.1, 4.3.5, and 4.3.7? Don't everybody
So
speak?
Linda Fox for the record, I don't see a 4.3.7.
This was, okay, so this was on the revised agenda. That I don't think it was made it into the first version of the packet, but then the agenda was revised to add Health Plan of Nevada, the Southern HMO report. Did you not get that?
I think I'm probably working off. Let me look and I'll.
Okay.
The other one. Okay. Apologies.
Yes, and Tom Verducci for the record. We do have a few different numbers here. Let's try scratching 4.3.7 and make it 4.3.6, the one that is referring to hometown health.
Okay, so you wanted to talk about hometown health, not HPN. Okay. All right, so do I have a motion? Go ahead. I heard Ms. Mitchell.
Yes, can you repeat those numbers again, please, Tom? Jet Mitchell for the record.
Yes, thank you, Jet. 4.2.1, the budget report. 4.3.5, Tower Watson's One Exchange. And 4.3.7, make that 4.3.6, hometown health.
Okay.
Thanks.
Okay, do I have a motion to accept everything but those 3 that Tom just read?
Jet Mitchell for the record, so moved. So making.
All right.
And I'll second that motion. This is Linda Fox.
Great. All in favor? Raise
Aye.
your hand so I can see.
Aye. Aye.
All right.
Aye.
Aye.
Perfect. That's unanimous, I think. All right. So with that, let's go back to 4.2.1, the budget report.
Yes, Tom Verducci for the record. I think I'll point this towards Laura Rich or whoever would like to respond, but looking at the operational budget, we look at the fiscal year of 2019, and we look at the change in cash, which was positive 11.9 million, and the net realized funding available was positive 31,600,000. Then we go into fiscal year 2020, and we look at the change in cash, and we see a big minus sign, minus 28,300,000, and the net realized funding available minus 15 million. And I was wondering if perhaps we could have Laura Rich expand on that and discuss how that's going to have future implications on the program.
For the record, Laura Rich, I think that this might be Carrie Eaton. I think she can answer this question. I'm going to pass it off to her. I think she's going to do a better job.
Thank you, Carrie Eaton, for the record. That number is basically, it's a timing issue. So basically at the same time last year, we received more revenue or expenditures than we did this year. So I think it's mostly the timing of our state subsidies that's causing that. And it's just timing at that point in time. Just a screenshot in time of our budget.
Okay, yes, because that's an alarming number, and I just want to make sure that we're addressing it and, you know, taking appropriate steps that, you know, we don't end up with a huge number that's going to be unbearable at the end of the year. So in terms of the timing issue, I think I partially understand that, but just want to bring attention to that since it's such a large number.
Yeah, so basically, you know, it's 28 million. Our Aegis subsidy is about 20 million a month. So if we don't transfer that before the 31st of March, then it's not going to show up until April. So it's all about timing right at that point in time. So it's nothing to be concerned with.
Okay, so with the future utilization report, we should not see such a huge aberration between these two numbers.
Correct.
Is that correct? Okay. Thank you.
This is Laura Freed. May I ask a question about the plan's financial position as of June 30th, 2020? If you look at the last page of the financial officer's report, we've got total revenues projected at the end of the year, and now we're on July 23rd. And so we're getting close to when we're closing out the fiscal year. Total revenues of 545.5 million, basically, and total expenses of 388.6 million. And then we've got restricted reserves for FY20 of 139.3 million. And so we've got some excess cash. Carrie, could you say a little bit about where we expect to be when FY20 officially closes on August 31st?
From what I can tell right now, we did have some claim suppression, which make our projected claims less. So excess cash to balance forward at the end of the year. Approximately, I'm guessing 14 million more than what was budgeted for 21.
14 million more or 14 million total? Because we had a budgeted excess cash of 6.5 million. Do you mean 14 plus 6 or 14 total?
I'm talking about the balance forward. So all combined.
Okay. All right. Okay, so that plays into a little bit of our discussions of stuff down the agenda. I just wanted to get clear on the implications of where we might be at FY20, how that plays into the subsidy holiday that, you know, the legislature just voted for in the 31st special session, and as well as policy decisions that are before the board today. So thank you for that.
And this is Laura. I just want to add that we are, to what Carrie said, we are in this situation only because of the claim suppression. We would probably not have seen any excess cash or not be in that type of predicament had COVID-19 not occurred.
Right.
I just want to make sure to emphasize that.
Right. No, when we met in the spring, we were looking at no excess cash. And I know that you've reported further down in the packet only about $500,000 in COVID claims costs, which is pretty darn low. So, okay, we'll get to talking about that. I don't want to, offend Ms. Mooneyhan by taking agenda items out of order. So with that, board members, do we have any other questions on 4.2.1?
Yes.
Okay.
I do. This is Tom Verducci. I also wanted to point out the total expenses and reserves. The very last column on the table, we're showing a difference of 4.359, and that's out of expenses and reserves. So is that indicating that we're seeing a decline in the reserves over the fiscal year?
This is Carrie Eaton for the record. No, Tom, that is only the difference between what our projection is showing and what was budgeted for this year.
Okay,
and what was budgeted.
Thank you for the clarification.
Okay, board members, do you want to, you know what, let's do this. Let's go to the other two items that Tom requested to be pulled, 4.3.5 and then 4.3.6, and we'll take all three of them at once. So let's do that, 4.3.5.
Okay, you had Tom Verducci again for the record, and I just wanted to address the performance guarantee that was not met with Towers Watson, and it looks like it was a customer service average speed to answer issue, and it looks like the outcome was 2.8 seconds, 2 minutes, 8 seconds. And I was wondering if we had Chris Garcia here that could perhaps address this issue and any appropriate steps that are being taken to correct it in the future.
Hi, Tom, this is Chris Garcia. Can you hear me?
Yes, Chris, you're coming in loud and clear.
Oh, perfect. And for the record, again, Chris Garcia with Willis Towers Watson's individual marketplace. Thank you for the question. I know that this measure was also one that was missed last quarter as well. As you look, the way that we measure these, I just want to add some clarity, and then we can talk about kind of what action steps happened or that we're doing going forward to make sure that this doesn't happen again, and kind of lead to why this tends to happen either in the last quarter of the calendar year or the first quarter of the calendar year. So when we have this performance guarantee, it's primarily based off of having a 5 minute or less average speed to answer in Q4. And then for Q1, we know Q1 is a little bit busier, and we'll talk about that in just a moment. And so that's 2 minutes or less of the average speed to answer. And unfortunately, we missed that by 8 seconds. As you mentioned, we had a 2 minute and 8 second average speed to answer for Q1. So it did lead to a penalty, which we have paid to PEB. It was a $2,000 penalty. It's $2,000 per quarter if there's a missed measure for this particular performance guarantee. And what we've seen historically in January is it really ties down to about the first 12 to 13 days of the month where we see an influx of calls that drive longer wait times. And that influx of calls and those longer wait times can tend to impact the entire quarter, which is unfortunate because as we move into February and March, we will tend to see lower wait times. So as I look at specifics for January, we were looking at specific wait times, and it was around January 1st through January 12th in which we saw much longer wait times than what we would like to see. A lot of that is driven off of participants calling in to do several things. One, they're checking on any new coverage that they may have enrolled in for the new calendar year. And two, they're checking on the status of any claims that they've submitted for their new premiums for the calendar year. So those tend to be the reasons why participants call us at the beginning of the calendar year in the first 2 weeks of January. What we also saw with the first quarter, though, was the rise in calls due to COVID-19 in March. We had an influx of calls, not necessarily for Nevada PEB participants, but for other participants on our platform, for other clients on our platform, that would lead to overall longer wait times for participants to reach a representative. Now, we did staff accordingly based off of available customer service representatives and our benefit advisors. We did have some people due to COVID-19 who weren't able to come into the office, but we were able to set them up so they could work remotely from home and still answer calls. But we know that there was a little bit of an impact there, transition people from working in the office in March to being able to work remotely from home. That could have led to a little bit longer wait times in the month of March than what we may have seen in prior years. So those are the main factors as to kind of what happened in the month of January. Again, primarily the wait times were impacted due to the first 2 weeks of January and then subsequent longer wait times that typically occur on Mondays or Tuesdays of each week. People tend to call us on Monday mornings, and that leads to longer wait times during that period, rather than calling, say, on a Wednesday afternoon or a Thursday afternoon, where you won't have as long as of a wait time. Now, what we're doing going forward, of course, is obviously we've been able to restructure our customer service representatives and our benefit advisors, where we have flexibility to have them work from home without any disruption if necessary. There are still some representatives and customer and benefit advisors that work in the office, based off of staffing availability, based off of the number of people that we can have in certain locations in the office to help minimize the spread of COVID-19. So that shouldn't be an issue going forward, but that was something that we did have to manage through during the month of March. That was not expected. And I believe that led to us having a little bit longer wait time than what we would normally have seen. And we may not have had a mismeasure if that did not occur. So that, I think, going forward, Tom, that should prevent mismeasures in the first quarter of each calendar year. Does that answer your question? Did you have anything additional based off of what I provided?
Jen Mitchell, for the record, can I please piggyback a Tom Verducci question too? On that same note.
Absolutely.
I see in January the abandoned calls 244, which is an alarming number. So to piggyback on Tom's concern about wait times would also be the abandonment factor of 244, which is quite substantial. And then in March, it says 29S. I'm not understanding if it's 29 seconds before a call is abandoned.
That's a typo.
So how many, were there only 29?
No, I'm happy to address that. And that is a typo. It should be 29, not 29 seconds. It should be the number of abandoned calls in that month was 29. With the S is a typo. But to address the number of calls in the month of January, so what's interesting, and I mentioned earlier how the most of the volume or the increase in wait times that we would see were in the first 12 days. And I actually have some data available. So out of the abandoned calls in the month of January, 192 of them occurred really from January 2nd, because we were closed on January 1st, but from January 2nd to January 12th. That's where we had the largest number of people who would have, quote unquote, abandoned the call. And so the average wait time for those abandoned calls would tend to be about a 5-minute wait time. So if people were calling in and they were, waiting to speak to a representative. They waited 5 minutes, hung up, and maybe they decided to call back later. We also put messaging on our phone system when we have increased call volumes or longer than normal wait times. That does try to prompt participants to contact us later because of the wait times that we're experiencing. And so we would see somebody call in, that call would start to count. They would get that messaging and realize, oh, I can call back later. They're experiencing longer than wait times. If I don't want to wait so long, then I would be able to call back. So again, 192 of those abandoned calls occurred within a less than 12-day period of time, where people were waiting probably on average about 5 minutes, in some cases a little bit less, before they were to hang up the call and maybe try back at a later point. Historically, it's not uncommon. If you look on the report, we have historical data a little bit later on say on page 9 and page 10 of the report, we have prior year historical call stats. And you'll see in the month of January, we tend to have a little bit higher abandoned call rate than in other months outside of November and December, which we're doing our Medicare open enrollment season. So if you look at page 9 of the report, so last year we had 89 abandoned calls in January. The wait times weren't as long, but we did have a larger number of abandoned calls. Then if you go back to the page 10, you'll see for 2018, we had 223 abandoned calls, very similar to what we saw this past year. So historically, it's not unusual to see a larger number of abandoned calls. It's just knowing that it all really happens in those first 2 weeks of January, just because of the influx of call volume due to those reasons that I mentioned previously.
Yes, Tom Verducci for the record. So I believe the penalty amount was maybe $2,000, and you're only 8 seconds off. But this is a second quarter in a row, and it sure would be nice to pull the next quarterly report, look at the performance guarantee met, see a clean slate with all yeses, and with the 2 quarters in a row, we kind of hope that would improve on the next report. So
this is Laura Freed.
Absolutely.
This is Laura Freed. I want to remind Mr. Garcia, as well as board members and vendors who are on the phone, we have a court reporter trying to keep an accurate transcript of this. When you don't identify yourself for the record, you make it harder for them, and you make it harder for the public who's trying to keep track of who's saying what. Please remember to identify yourself for the record.
This is Marcia Urban for the record.
My apologies.
This is Marcia Urban for the record. I mean, you're saying that in 2 weeks in January, you always have this problem. For some reason, it was better in 2019, but it's gotten much worse in 2020. So then what are you doing to make those changes in that 2 weeks so that, I mean, this is a historical problem. It's not like 1 year was an oddball. I mean, this is something that happens yearly. So what are you doing to rectify that?
Chris Garcia for the record. Thank you for the question. And my apologies for not introducing myself or restating who I am each time I've spoken in the past. I'll make sure I do that going forward. So to address those, I mean, the part of the challenge is when we run into the month of January, we maintain full staffing. And you can see that the call volumes in the month of January, and just looking specifically at the Nevada PEB numbers, they are higher than, say, the subsequent months. So for February and March. So it's what we call all hands on deck. And we have full staffing. All of our customer service representatives are available. We have additional resources, such as what we call our application data processors, who are trained to not only process applications for enrollment, but to also answer customer service calls. They're taking those customer service calls as well as processing applications. So we try to maintain full staffing in the month of January. And when we look at hiring on customer service representatives, the hiring process really begins all the way back in the summer. And we gear up, we bring on new representatives, we bring on additional benefit advisors and application data processors, and they are trained starting in the summer, gearing up for Medicare open enrollment, which is really in October, November, and then the first part of December. Those customer service representatives that we've hired to what we call seasonal employees, they'll come on and they'll help us during the month of January and into February as necessary. So we bring on as many representatives as we can, and we staff as best as we can based off of available talent pool, based off of call projections, and we manage that way. So in regards to what we're doing, it's really looking at what potential impacts can we have that might drive call volume and staffing accordingly based off of that. We did add messaging. I mentioned this earlier. We did add messaging to our phone number or our automated system to advise participants if they're calling in, if they're longer than normal wait times. That's something that's new this past year that we didn't have in prior years, that we hopefully will drive participants to, if they call on a Monday morning, as for example, or they call on a Tuesday morning where it's busier, they can maybe call back later in the week where it's not so busy and they're not having that longer wait time. So while we certainly agree we don't want to have these long wait times, and I don't want to have back-to-back quarters where we're missing the measure, and granted we only missed the measure by 8 seconds this past quarter, I agree 100% that it's still a missed measure. It's not something that we were geared to happening, but it is something that did occur. We don't believe it's going to happen, this past quarter that occurred, which is Q2 of the calendar year. Not going to happen for Q3 of the calendar year, because in the summer, the call volumes tend to taper off and we're able to manage those call volumes more successfully. So in regards to what we're doing, I believe the correct answer is looking at staffing, looking on bringing those associates, that we need to address the call volume accordingly. But other than that, there isn't much else that we can do outside of bringing on the right resources to address the initial call volume that we target.
Tom Verducci for the record. Chris, I did want to ask, does your call center provide for automatic callbacks during busy periods? When you occasionally you'll call a call center and there'll be some call wait. Do you provide the ability of the member to leave their number and then get a call back? Or is that something?
Mr. Verducci, Chris Garcia for the record. Again, thank you for the question. Right now, we do not, and there's a specific reason as to why. Medicare enrollment calls, so if somebody wants to enroll in a Medicare Advantage plan or a prescription drug plan, they have to be done by an inbound call. They cannot be processed through an outbound call. So that's one of the main reasons that we don't have that functionality in our system. It's something that we are exploring. They've recently allowed us to do Medigap enrollments through an outbound call, as well as dental and vision enrollments. So that's something that could potentially, we could see this coming open enrollment season, but it's not something that's in the system right now.
Okay, thank you for addressing that. And it's good to know that it's something you're working on as well.
Jet Mitchell for the record. I want to piggyback my previous comment about call abandonment, and I appreciate Chris Garcia's comment in January that we had 192 calls from January 2nd through 12th that were abandoned calls, but that does not answer why there was 605 in November and 668 excuse me, in December. So I'm not looking for Chris Garcia to make a comment on that. I just wanted to note to board members that the call abandonment question that I raised was not a January only situation. And as Marcia Urban well noted, the historical problem earlier, I just wanted to make sure that that historical problem was noted as November being 605 abandonments, December 668 abandonments. And again, not looking for a specific explanation on that, but just noting the abandonment trend was not just January 2nd through 12th. And again, this is Jet Mitchell for the record.
Thank you. This is Laura Freed. Thank you for those comments, and a thank you for the incisive questions. Board members, are there any other questions for Towers Watson? Okay, hearing none. I see a head shake from Mr. Verducci, so that's a no. Let's move on to 4.3.6.
Yeah, okay, well, Tom Verducci again for the record. This would be in regards to hometown health, and in looking at the past fail, we have a fail that had jumped out here in the claims repricing. The guarantee was 95% turnaround time, and for repricing of medical claims within 3 business days of receipt from PEB's third-party administrator, and it came in at 89%. So perhaps we have a representative from Hometown Health. That would be wonderful.
Good morning. Can you hear me? Well, good morning. Perfect. Madam Chair, and to the board, for the record, I'm Heather Reimer, Director of Self-Funded Programs at Hometown Health, and thank you for giving me the opportunity to speak to this item. Hometown Health provides the PPO network and reprices claims for the TPA, and as part of that agreement, we have performance guarantees. Under the EDI claims repricing guarantee, the measure is 95% turnaround time for repricing claims within 3 business days. During first quarter 2020, we failed that measure at 89%. During Q1 each year, we load new fee schedules. This often requires us to pen the repricing file while we receive and process fee schedules for the new year. In this quarter, there was a delay in receipt of the Medicare fee schedules, which resulted in missing this measure. All their measures for the quarter for Hometown Health were met. Can I provide any further details to that for you, Mr. Verducci or board members?
So Tom Verducci for the record. So what steps are going to be taken next quarter? If you could expand a little bit more on that, so when we get the report, it has a pass.
Absolutely. Heather Reimer for the record. This fee schedule and all the fee schedules have been loaded and are currently working appropriately. So we don't anticipate failing this measure next quarter. This really is based on a dependency of an outside agency receiving those fee schedules. And we typically have this process during Q1 of each year for each cycle. So we can load those new fee schedules of the new year.
Okay, so you'd anticipate getting a pass for the next quarterly results at this point? Or does this look like a problem that could be persistent?
Heather Reimer for the record, I do not think it's persistent. We are really diligent about ensuring that our fee schedules are loaded as soon as we receive them and in order to provide a timely repricing file.
Okay, and thank you so much for addressing these issues. And I think that's it on my comments there.
You're welcome.
Okay, this is Laura Freed. Thank you for that. Any other questions on 4.3.6 from the board? Okay, hearing none, I would accept a motion to accept the reports under 4.2.1, 4.3.5, and 4.3.6.
For the record, Don Bailey, I so move to approve those.
Great, thanks.
Tom
And then
Verducci,
Fox for the record,
second
that motion.
I think Mr. Verducci spoke first, but so I'll give it to him. Okay, it's been moved and seconded. All in favor, say aye or raise your hand on your picture.
Aye.
Aye.
Jennifer
Any
Kress,
opposed?
aye.
Okay, any opposed? All right, passes unanimously. Thank you, everybody, for your questions and your testimony. Let's move on to election of board vice chair. This is agenda item 5. Let me flip my packet. Okay. Since this is the first meeting of the new plan year, Nevada Administrative Code requires us to, again, elect a vice chair who presides over the board when the chair is unable to do so. As the board knows, Linda Fox is the current vice chair, or was the vice chair for plan year 20, I should say. And Ms. Fox has expressed interest in continuing. I have not received myself any other formal expressions of interest. So I want to, as the agenda item notes, the eligible candidates are Mr. Bailey, Ms. Fox, Mr. Verducci, Ms. Urban, Ms. Krupp, and Ms. Mitchell. So if you'd like to nominate someone, you may. If you'd like to nominate yourself, you may. And if we have more than one nomination, I'll just ask each person who's interested to say a few words about why they would just love to be the vice chair of the PEB board. With that, I will open it up.
Jet Mitchell, for the record, Chair Freed, I would like to nominate Linda Fox to continue her service as vice chair.
Do I hear any other nominations? Sorry, this is Laura Freed. I got to take my own medicine. Okay, I'm not hearing anybody speak up. So with that, let's see, Ms. Rich, we officially have to vote on this, right? With a motion and a second. Okay, thanks. Got it. All right, so Member Mitchell, would you like to move that Ms. Fox continue her service as vice chair for plan year 21, and I'll solicit a second from the membership?
Jet Mitchell, for the record, Laura Freed, Chair Freed, yes, that is exactly what I would like to do.
Awesome. Do I have a second?
Marsha Urban, for the record, I'll second that.
Great. All in favor, say aye or raise your hand.
Aye.
Aye.
Aye. Aye.
Jennifer Krupp, aye.
Any opposed, say no. All right. Sounds unanimous. Thank you so much, members. Congratulations, Ms. Fox.
Thank you.
You may get another shot if we have another special session. You may have to preside over a meeting or two. So,
Okay.
All right. With that, let's move on to agenda item 6, the executive officer report. Ms. Rich.
All right, for the record, Laura Rich. So this is agenda item 6, the executive officer report. It starts out with plan year 21 open enrollment. So typically after each open enrollment, PEB reports any type of migration that occurs within the plan, just to give the board and the public some idea of, you know, what happened throughout open enrollment. And long story short, there wasn't a lot of changes in the member enrollment. I personally was expecting some migration given the higher premium cost of the HMO and EPO. But as you see in that chart, the numbers are pretty steady. The numbers between each of the plans, between plan year 20 and plan year 21, it almost went unchanged. So again, there's a level of consistency there. The next one is the COVID-19 update. PEB continues to encourage those staff who can work from home to work from home and to continue doing so. But we were able to purchase some laptops and get some VPNs and things like that. So we're able now to move people away from the office and work remotely to encourage that social distancing. And it's been a little bit of a shift in the way we do things internally in the office, but I think that we're doing really good in adapting, and we're looking at possibly making some changes within the call center. That was our biggest challenge as far as being able to have all staff be able to work remotely. But really we are adapting and things are looking good there. So since the plan is also, we're paying 100% of COVID-19 claims, we've been keeping a very close eye on claims cost. These are also being reported to the governor's finance office, just in case there's any applicable federal dollars that we can get back on that. And as of this week, we do have a work program approved for $400,000 of COVID-19 related expenses. So we will be getting some federal dollars back from that. So as of July 13th, and actually I got the updated numbers yesterday, they're not much different. The plan has paid approximately $550,000 in COVID-19 related claims. And I just want to put out there that that number does seem low, but you have to remember that these expenses, these COVID-19 expenses were incurred during a time where the state was shut down, where we had, stay-at-home orders, and everything was typically, in shutdown mode. And so cases at the time were reducing, and so the situation was different. If you recall Aon's COVID-19 modeling that was presented back in May, they presented a few different models. So it was best case scenario to worst case scenario, and there were 3 different ones, right? So the best case scenario is where the state is closed down and everyone's social distancing, and we've got a state of shutdown type thing. And in that scenario, PEB actually, the program saved money versus incurred costs. But if you remember in their scenario where they assume that we move to phase 2, we open nearly a full open on July 1st, which we actually did that before July 1st. And then a rise in claim or a rise in COVID-19 cases, which then leads back to a stay-at-home order on August 1st. Now, we don't have a stay-at-home order. We're not shutting things back down, but I wouldn't say that's out of the realm of possibilities. So I'm looking at the Aon's model as a possibility, a real strong possibility of, the kind of the worst case scenario. And if you look at that chart, you're looking at if we have a low claim suppression and a low claims cost, we're looking at best case scenario, or I'm sorry, high claim suppression and low claims costs. We're looking at a best case scenario of the plan saving about $2.7 million. However, in a situation where it is worst case scenario, where we have a low claim suppression and a high COVID-19 cost, that could cost the plan about $20 million. So I guess the general message that I'm trying to relay here is that it's this $500,000, this $500,000 that we have paid out in COVID-19 claims. I think this is, really best case scenario for right now, and that the situation could definitely change given what we're seeing right now as far as the rise in COVID-19 claims and hospitalizations, and not just in Nevada, but across the country. So I just wanted to make that clear. It's something that we continue to watch, and it's something that we will have to continue to just keep a close eye on. I will have Aon present a new updated modeling at the September board meeting. I think that will give us a little bit more insight into what is happening and what we can expect. So moving on to the COVID-19 coverage, I just wanted to provide the board an update that back on March 31st, the board did elect to align with the governor's emergency regulation by covering all testing and office visits and treatment related to COVID-19 at 100% of the plan's maximum allowable charge. That emergency regulation went into effect through July 3rd. However, staff was provided the authority to extend that coverage should the regulations be extended or reissued. And that is exactly what happened. So that the regulation attachment A, you will see, It was filed on July 2nd and was intended to replace the March 5th emergency regulation. So PEB is continuing to provide that coverage as we had been as of March 31st. Then there's the solicitations update. I will what PEB staff and board members who, thank you very much, who have been out with this process. We are very, very, very busy with solicitations right now. We have 5 solicitations that we are working on actively, really 4. One with the last one, we have a little bit of extra time to work on, but 4 of them, we are really in a time crunch and need to get them out and really implemented by July 1st of next year. So staff have been working really, really hard around the clock to get these solicitations ready. We do have one out right now. The enrollment and eligibility benefits management system is out. And there's going to be 3 more back-to-back that are coming out, within the next month or so. So that's basically going to be what PEB is going to be working on for the next year. Between right now, we're developing those solicitations. There will be the evaluations of those proposals, and then following that, there will be the negotiations. It'll be presented to the board, and then approved at BOE. And then we have the implementation part of it as well, and the communications to members and things like that. So long story short, we are going to be very, very, very busy for the next pretty much year. The one thing that is not in this report that I did want to add is the special session update. That wrapped up on Sunday. So that was, that's why it's not in this report. I wasn't able to add anything in there. The report was written before it wrapped up on Sunday. But I wanted to make some clarifications because I received many, many emails on what exactly was PEB's role in this. And so in this special session, look at AB3, this was the bill that included all the administration, the state administration, so the furloughs, the increase of annual leave rollover. Thank you, Chair Freed. And there was also the part on PEB. And so really what the PEB portion is to allow that subsidy holiday. So the PEB board voted back in May to, it was about $25 million in budget reserves, but we have a statute that doesn't allow PEB to really to take that money and just give it to the state, right? The PEB money stays within the program. And so the only way to go about moving those funds that we set aside for reserves into the general fund is to allow for a subsidy holiday. So what this bill did is allowed for the agencies, not the employees, and that is the clarification that I want to make, is that agencies get a subsidy holiday for 1 month of the fiscal year. That month has not been identified yet, but they do get 1 month of a subsidy holiday. And so that's 1 month that PEB does not bring in the employer portion, so the employer contribution. And that's essentially how that $25 million that we set aside goes back to the general fund or the programs to which, those agencies that are paying that employer contribution. So I wanted to clarify that because I know that there's this language in that bill that does state that employees are not, they're not responsible for that portion. And there was some confusion as to whether employees were responsible for the premiums at all. And really what it's saying is that employees are not responsible for the employer portion of that contribution. So I wanted to put that on the record because I think it's helpful and really clarifies a lot of the questions that I've been getting. coming into the office. So with that, I will conclude and give you guys the opportunity to ask some questions.
This is Laura Freed. Thank you for clarifying the difference between a rate holiday, a subsidy holiday, and a premium holiday, because people who are not in the PEB world, except maybe as participants, and people who are members of the press and certain members of the legislature use those terms interchangeably, and they mean very different things to people who understand the plan. So thank you for that. If I may I go back to page 2 and the Aon's illustrative chart? So tying this back to the conversation earlier in the meeting about the fiscal officer's report. So again, I know this is just a chart for illustration purposes, but the fact that we have excess cash that we had not planned on and projected earlier in the fiscal year, or early in FY20, I should say. So just to be clear, we are low on COVID claims costs and high on claims suppression, which is what explains the excess cash. Is that a fair statement?
I would say that is a fair statement, yes.
Okay, thank you. Board members, other questions for Ms. Rich?
Jet Mitchell, for the record, I have 2 questions for Laura Rich on the report. First of all, I wanted a little clarification on the number, the 550,000. Do we have some kind of a sense of where that is going? What does the 550,000 represent? So that's my first question.
So that 550,000 is any COVID-19 related claim. So when a member goes in and receives an office visit or any testing or anything like that, it is there's a CPT code that's associated with it that is that's COVID-19 related. So that is anything paid out that is related to that CPT code.
And actually, I have 3 questions. Sorry. So I'll say 1, 2, 3. So 2. Follow up on that, your comment, if we end up having a more of a worst case scenario, the claims would be COVID related for hospital, I'm assuming hospitalizations would drastically increase. Would that be a fair assessment?
Yeah, so Laura Rich, for the record, yes, I would say that's a fair assessment. That is where, the bulk of the cost rate. So the testing is costly on a volume basis, but obviously a hospitalization would be costly in general.
Okay, and Jet Mitchell, again, for the record, I asked question 1, question 2, and then I have the third question on the special session update. You had identified the subsidy holiday month. Do we have an idea as far as when that month will be identified, or further color around the timeline of the holiday month? Or how does that look for us at this point?
So for the record, Laura Rich, if you recall, a lot of a significant percentage of what we put aside in reserves it came out of the reserves bucket, right? And so it's already there, but there's a portion of what we had set aside for those budget reserves that are going to accrue throughout the plan year. And some of them don't even accrue until, or don't materialize until May. If you think back to that HRA that we made, that will not even happen until the end of May. And so my assumption, we will work with the governor's finance office on this, but my assumption is it will be, if not the last month of the fiscal year, it will be very close to it.
Jet Mitchell, for the record, thank you so much for the clarifications. And I know in discussing COVID, I completely understand that we're in unprecedented times. So we're discussing ranges of possibilities that could be total claim suppression to no claim suppression whatsoever in every scenario in between. So I know we're asking, as board members, we may be asking you to look into a crystal ball that may or may not we don't know what that looks like at that point. So I am cognizant that there's a lot of unknowns at this point and continue to be so.
This is Laura Freed. May I key off what Member Mitchell asked about what does that $550,000 consist of? When I'm reading the health scope reports and all of us for agenda item 4, is COVID classified a disease of the respiratory system or the circulatory system, or is it other, or where would I look for that?
That is a very good question, Laura Rich, for the record. I think we have Mary Catherine on the line, and she may be able to speak to that. I don't know if they're I really don't know where they're incorporating that.
This is Mary Catherine Pearson for the record, and it could be incorporated in any one of those places. As you know, it really falls into a lot of different areas. In the current reporting, you really wouldn't see it. You'll start to see more of it actually in the set of reports that you'll probably see for the September board meeting. But currently, there's not a lot of data in there. A lot of the initial cases really probably fell into the respiratory more than other places, but it's kind of a mixed bag today.
And Jet Mitchell, for the record, Mary Catherine, would it be fair to say that as time goes on and we know more both about COVID and treatment, that certainly 6 months from now and maybe even a year from now, the board and all of PEB members would have a better look at how much was spent and exactly in what buckets it was spent? Would that be a fair assessment?
That is fair. This is Mary Catherine Pearson for the record. We will be providing, and we are providing you guys and can continue to provide on an ongoing basis a rolled up view of just COVID-19 as well. So you can see the exact costs specific to COVID, specific to inpatient, how many patients were on ventilators, all of those different types of things are all things that we're tracking on your behalf. And we can provide that information on testing, the numbers and percentage of people who are actually positive, those who are presumed positive, because there's been an interesting combination of the way providers have actually sent in claims regarding COVID.
And Jet Mitchell, again, for the record, Mary Catherine, I'm also very interested in 6 months and a year, how claims would look for other things. I specifically follow cancer patients for personal reasons, but for example, many cancer patients are deferring treatment and diagnostics, which is most unfortunate on a personal level, but it would be interesting to see claims that are not necessarily COVID specific, but are COVID spillover effects. And I think PEB may see that in the next year as we have other chronic diseases and other health issues bubble up that were suppressed, that had issues, claim suppression and otherwise during this time. So I'm hoping that's not the case, but the research that I'm reading shows that it may be that we'll see further increases in additional things in addition to COVID specific. And I hope I'm wrong.
This is Mary Catherine Pearson for the record. I agree with you, Dr. Mitchell. I believe that that's very likely. And if it's something the board would like to see, we can work with Aon to put together some reporting for your September meeting that's specific to some of those things.
Jet Mitchell, for the record, I would work with, my thought is I would defer to Laura Rich and Laura Freed as far as some specifics, but it may even go beyond September. We may be looking well into 2021 for, I say spillover, other unintended consequences of this dreaded COVID that will affect the PEB participants as a whole.
This is Laura Freed. Yes to the September reporting, and I think if we haven't imminent vaccine or vaccine candidates by the end of the calendar year, yeah, I think the board would be very interested in continuing that as HealthScope sifts through all the various ways that providers have reported COVID claims to you guys. So thank you for that.
And this is Laura Rich. Chair Freed, you bring up a good point there. Vaccines, that's going to be a significant cost to the program as well as when that is developed. So that's something that we will need to, track as well. So, we're hoping that, there will be some federal assistance if that does come out, that, that's covered as well. But that's one of those things that we're looking at and making sure we watch.
Okay. Laura Freed again for the record. Other questions on the executive officer report? Okay. Okay, hearing none. Board members, agenda item 7 has to be deferred because the LCB audit subcommittee that was scheduled for July was preempted by the 31st special session. So the PEB staff doesn't have much to report to you about the progress of its audit. So we'll skip that and come back to it in September when we probably will have had the meeting. So let's move on to agenda item 8, results of the RFI for actuarial review and benefits management system.
All right, so for the record, Laura Rich, back in January, at the January board meeting, the approve some further analysis. This is back when we were thinking about the budget and looking at possible enhancement requests, and when our fiscal situation was looking much different than it is today. So there were some things that the board had approved to really, for staff to take back and start looking at and doing further analysis on, and 2 of those were requests for information. One was for the actuarial review, and another one was for an eligibility and enrollment system. So this report basically provides an update to the results on that. This is really for information only, because at this point, there's very little chances that enhancement units are going to be approved in any budget at this point. So the actuarial review services was one of those budget enhancement requests, and it was received from the advocate groups. They wanted an actuarial review of Aon. So the intent was to provide independent verification of the actuarial services provided by Aon to PEB. And so in order to have a better understanding of the cost for this type of service, we put out an RFI, which is a request for information. We received some responses on this. We received responses from Wakely Consulting Group, Diamond Consulting Group, and the Siegel Group. So 3 responses. And basically the cost proposals, the way that we received the cost on this was different for each one of the years, but ultimately the average price overall, the way that they priced them out overall, it's going to cost the program, should we look at this option, about $100,000, give or take. So again, this is for information only, because this is likely not something that we have even the opportunity to request at this point, given the different budget scenario that we're in today. The next one was the eligibility and enrollment system. And the reason that an RFI was requested for this is because we needed to prepare just in case that the 2-year contract extension was not granted or canceled. And that's in fact what we did. I didn't go into a lot of detail on this one, on the results of this one, because we have to remember that there is an active solicitation. We we have an RFP out on the street, and my assumption is that those vendors who responded to the RFI will also be responding to the RFP. So I kept this high level to, maintain the sensitive nature and the confidentiality of, the solicitation process right now. But we received 8 responses on this RFI. And really, because this is an RFI and not an RFP, the responses as far as cost went were all over the board. And there was, because it's a very complex system with a lot of variables, it's very hard to price unless you have all of the, unless the vendor has all the information in front of them. So we are expecting higher PMPs than what we're paying today. But we don't know. This is something that, where the solicitation is out right now. We have actually last night received the second set of questions. I think we're up to close to 100 questions on this. And so I'm excited, and I think that this solicitation will be positive for PEB. But again, there's not a lot I can divulge at this point as far as what the RFI results were, just because I want to continue to maintain that confidentiality of the RFP processes out right now. So in conclusion, things have changed. This pandemic has changed the economic landscape of the state, and there's probably little chance that we can really leverage, especially the actuarial review RFI at this point. But at least we have a better idea of what the cost was for that. So with that, I will take any questions.
This is Laura Freed. Board members, I'm not hearing anything. All right, so this is an information item only. So without any questions, we can just go ahead and move right on to agenda item 9. Possible discussion of plan design changes for FY 2022 and 2023.
Okay, this is the big one. Laura Rich for the record. So each biennium, state agencies must build and submit an agency budget to the governor's finance office by the end of August. Budget request undergoes review and pretty often numerous modifications before it eventually becomes part of the governor's proposed budget. GovRec is what governor's recommended budget, or GovRec, presented in January prior to the start of the legislative session. So under normal conditions, agencies receive a set of instructions and general directives in the spring prior to the August budget submission deadline. And that is exactly what happened. But the COVID situation changed everything, right? Now our revenues are different. The state is in a much different situation than we were in back in February, I believe, is when we had this meeting. So the special session took place earlier this month and focused really solely on resolving the more immediate FY21 budget shortfalls. But it hasn't really, we don't have a lot of direction on the FY22 and 23 budget building. What we can assume is that there will likely be some sort of cuts, but what we do know is that PEB was issued a basically caps to our program back in February. And that's really what we're working with. So what we have decided to do here is what is prompting the changes is that we're faced with a budget constraint, number one, and we don't want this to be borne on the backs of our members. So what we did was we had strategic planning session back in May. And we talked about the goals of the program. So this was staff, it was vendors, and several board members as well. And we talked about, what are the problems, issues facing the program, and what can we do to make improvements while still adhering to the budget limitations that we have today. So we took this opportunity to kind of, try to revamp the program. And in addition to everyone that we had participating at the time, we had asked feedback from the advocacy groups as well. And we did receive some feedback with, essentially the recommendations or the asks from the advocacy groups. So what I want to start out with is first talking about all of the different variables that we're being faced today and what can change this this scenario moving forward. As you know, there's a lot of unknowns right now in the program, so I wanted to just kind of set the stage and say, look, this is what we think is going to happen. We're going to present some of this information, but there are so many variables at play that we need to, keep in mind that there's significant changes or significant factors that can change what this looks like by July of next year. So the first one is contracts. As you know, we have 5 contracts up for renewal, one of those being pretty significant. That is the medical network. And if that changes, the cost could change dramatically, up or down, we don't know. And so this can definitely affect the outcome and the cost of the program and what the claims costs are going to be. So this is definitely a big variable out there right now. And, as I said, COVID-19, that is a huge unknown right now. We don't know what those costs are going to be. We don't know, if COVID related claims are going to increase, if we're going to be faced with covering, vaccines and hospitalizations and et cetera, et cetera. So, that's a big unknown right now. We also have trend. The pandemic will undoubtedly have an impact on trend. So medical carriers right now are anticipating, and we'll hear Stephanie talk later about trend and rates and what she's expecting. But they're anticipating anywhere from a 0.5% to a 1% increase in 21 trends. And that's basically because of claim suppression in 2020, right? That last quarter of 2020, we saw a lot of claim suppression. People were not going to the doctor. They were not getting medical services. They were postponing their surgeries and elective surgeries like that. So these are all things that can contribute to trend. Now, what is that going to look like a year from now, right? There's a lot of unknowns. And then we have the state economic conditions. We don't know what the state fiscal situation really looks like at this stage. We don't know what topics and where the legislature is going to stand come next session when we're talking budgets and what the state is able and willing to contribute towards benefits. So this is also something that is, it's big. Right now, the employer contribution is, sits anywhere from about 91 to 96% of the total premium. So it's big. If that contribution is reduced, then, we're faced with some decisions on our side as well. So that's just kind of level setting things and setting the stages to, there's a lot of variables out there. There's a lot of things that can change, but we are trying to be proactive and really make plan design changes that improve the program without cost. And so this is really what we were working towards when we did this. So the plan design changes that we are presenting today, the first thing I want to emphasize is we are only presenting the concepts. where all the numbers in there can change and probably will change because we have very premature data at this point. What we need from the board today is to really approve the concept because we have to build a budget based on that concept. And so the preliminary plan benefit design that's shown, all those deductibles, co-pays, and co-insurance are, they're just there for an example. And in November, when we have more information, we can really start drilling down and looking at those numbers and figuring out where PEB as a program stands and what we can adjust and and how much we can adjust those levels at that point. So when we were looking at revamping the program, we identified some goals in that process. First, we wanted to improve the plan options so that members had more appropriate plan selections. You've heard over and over that there's a low deductible. There's a desire for that low deductible. Members want another choice. Sometimes there's a lot of members who, neither of our plans really fits their needs. They want something in the middle. So that is something that we tried to work towards, is how can we develop a third option that meets the needs of members. The other one is we really wanted to make things more simple for members. And right now, the CDHP, for a lot of members that really don't understand healthcare, the CDHP is pretty complicated. So when we thought about introducing a middle tier plan design, we wanted to make it simple and kind of get away from the whole co-insurance option and really stick to co-pays. And so that is really, even though there is a deductible in that, in the middle option, the deductible really only applies for specialty meds. Everything else is a copay. So it's a fairly simple option for people to understand. You go to the doctor, you pay a copay. You go to a specialist, you pay a copay. You go get your medication similar to the HMO and EPO. It's based on a copay model. So those were the two goals that we identified. The third one, of course, was reducing cost to PEB. We weren't given a specific reduction. Agencies have not been told this is what your what your new target is. We've been given initial caps for our program back in earlier this year, but we have not been given any more direction from the governor's finance office. I think that at this point they've been dealing with FY21 matters and are just now starting to look at FY22 and 23. Unfortunately for PEB, we don't have the luxury of waiting around. We must plan well in advance in order to be able to to roll things out in July. So what we did was we developed two plan designs. Basically, one is at a 5% reduction and the other one is at a 10% reduction. Both of these ideas get us to the $299 million cap that was identified earlier this year from the governor's finance office for the Public Employees Benefits Program. So if you look on page 4, you'll see the proposed plan design changes. You'll see that we modified the CDHP, the high deductible plan, and really what we did there was we modified it by we increased the deductible and the out-of-pocket max, depending on if you're looking at the 5% or 10%. The deductible at the 5%, it goes from $1,500 to $2,000 for an individual and $4,000 for a family. And then if you look at the 10%, it's up to $2,500 and $5,000. In the 5% bucket there, the HSA employer contribution is lowered to $500. And in the 10%, there is no HSA contribution. Now, the modified CDHP is really, it's for those people who either want to have an HSA and want to contribute to the HSA and really want, you know, they're healthy. They don't go to the doctor very often. They don't seek services. They are they need insurance and they want coverage because they're responsible individuals, but they don't need something that is so they don't need that extensive coverage, right? So then we have the low deductible PPO with copay. This is the new plan that we offered, and it's in the middle, right? It's that middle tier option where you see a deductible. But again, I want to emphasize that the only place that you're meeting that deductible is for specialty meds. Everything else has a copay. And the 5% is you're seeing that, you know, some of these numbers again might change, but this is just to get an idea of what this plan might look like. You're looking at your primary care visit, $30, your specialty visit, $50. If you go to the ER, $750, right? Your generic meds, $10, formulary, $40, non-formulary, $75. It kind of gives you an idea of where we land in that copay plan. And then you've got the EPO and HMO. So that was adjusted a little bit as well. We added a deductible to that. Again, that deductible really only applies for that specialty medication tier. But the premiums, and I didn't put the premiums in here at the time because we didn't have them, but I had asked Aon to develop maybe what those premiums are going to look like in today's numbers. Again, this is all premature. We don't have a lot of up-to-date data, but I wanted to provide something to the board members and to the public so that you can get an idea of, you know, what these plans are going to cost with the information that we have today under the assumptions of, our current budget situation. So in the report, I have that the premiums, obviously the modified CDHP is going to be the least expensive premium. And then you've got that middle tier, the new plan is going to be a middle option. That's going to be priced between the CDHP and the HMO and EPO. And then obviously the EPO and HMO, which has the richest benefits, are priced the highest. So I'm gonna pause right there because Stephanie from Aon is going to be, she has some rates available that she's going to present that can kind of give a better idea of, you know, what this is going to look like should we, roll this out today. Now, keeping in mind with that disclaimer that things will change between now and the time that this is implemented. So Stephanie, I'm going to pause right there. Are you ready to share your screen and present on the rates?
Yeah, I am. Can you hear me okay?
We can hear you.
Perfect. Yes, I am. All right, we'll get my Excel pulled up. Okay. All right, are we able to see it? Perfect, I see Laura Freed nodding. Thank you, Chair Freed. Once again, for the record, my name is Stephanie Messier and I'm with Aon. So as Ms. Rich alluded to, these are very much draft numbers, but we certainly understand it's very hard to talk about plan design changes without really knowing what that might mean to employees. So we have a couple of different scenarios that we wanted to go ahead and show you this morning. The first one that I'm going to show is that modified plan design changes. So it's really those middle columns that Ms. Rich just walked us through. It's the 5% plan design change scenario. Some other key assumptions that are going into the rate building is probably the largest one that's the most impactful and is a little bit of a risk is that right now I've assumed that PEB is able to keep medical, pharmacy, and dental costs flat in total from where we've set the plan rates today for plan year 21 going into plan year 22. Definitely more aggressive than you've seen from us in the past. But I'm also trying to be mindful of the fact that when Nevada was coming out of the recession, probably around the time that the CDHP plan was implemented, you all did see some pretty serious reductions in terms of utilization of the plan. Certainly, we recognize that when the economy is in a decline or the tourism industry is impacted, especially for you all in Nevada, it can cause a pretty systemic shock to the system. So you may very well see people using the plan less in 21. Conversely, as we've talked about this morning, there's the COVID unknown out there. So delaying care, which as Board Member Mitchell indicated, that could also cause people to become sicker as they've been delaying care for the last 3 to 6 months, being concerned about going into the doctor's office, or again, worrying about maybe their paychecks for their spouse not coming in or currently being laid off or furloughed. So there could be a bunch of claims reductions that you all see in plan year 21 that start to return either in January of next year or could roll over into plan year 22. But there's certainly a chance that either we're also able to make some cost saving measures in terms of not just design changes, but things like ESI has brought in the past that save us on pharmacy and those other items, or Health Scope benefits could also find the ways to save the plan money for plan year 22. So we did want to get a little bit more aggressive than we have in the past. And that's what you're seeing here in this particular assumption, where we're saying costs remain flat for plan year 22 or 21. And it's possible that you're going to see some claim suppression throughout plan year 21. So any kind of trend you see over that is going to be incorporated into the fact that I'm going to set the plan year 22 rates at the same level we set 21. Perhaps 21 was set too high with claim suppression coming in below that. So it's still giving you maybe a decent footing to start plan year 22. But as we keep alluding to, there's a lot of unknowns at this point in time. The other assumption that's going in here is that the state subsidy needs to be kept in total at $299 million, which is a 5% decrease from plan year 21. And our current indication is that the amount remains constant for everyone into plan year 23. The difficulty there is, as we all know, medical costs continue to rise year over year. So if the state amount is staying for both plan year 22 and 23, any sort of an increase that's out there gets fully pushed onto your employees because, again, that employer dollar is staying static. The other assumption I used in these rate builds that you'll notice for the plan year 23 column is that I did move it forward with a modified trend rate of about 5% when blended, all of the 3 different products combined, the medical, dental, and pharmacy, for 5%. That's still a fairly aggressive number as well. It's possible we'll start to see higher numbers, but I really wanted to be cognizant of the fact that you all have generated excess reserves in the past. And so we're getting a little bit more rosy, if you will, in terms of our predictions here for plan year 22 and 23. Below in the chart, you may be used to seeing this when we post it, and it shows the total and then the employer and the employee. For the ease of trying to view this on the computer screen, I'm instead just showing you the employee's portion of the cost. So currently in plan year 21, employee only on the CDHP plan are paying about $44 today. Under the new plan design changes, where we're shortening the HSA funding to $500, we're increasing the deductible and out-of-pocket maximums, as well as applying a 5% reduction in what the state is providing. That's just a little bit more cost to the employees. It goes up ever so slightly, about 50 to 60 cents for the singles. There's a little bit more, $7 change for the employee plus spouse. And because of some of the other changes we're going to get into in agenda item 10, it's a reduction on the family side and a little bit more of an increase on the employee plus child tier. And some of that's a result of the tiering, which we can get to later. Then moving those numbers forward to plan year 23, because again, there's a trend happening and the leveraging effect occurs. The stated portions of those rates stays the same. So the full 5% increase on total medical claims is now put onto the employee. So that causes a fairly sizable increase of $30 almost on the single coverage for that CDHP plan. and up to about $70 on the employee plus family. Moving to the new copay plan, just so you can see the relativities as to where this plan may land in relation to the CDHP plan. It's going to be about a $61 plan alongside of the $44.50 plan on the CDHP. So the benefit here is, again, members will be able to move to a copay structure. So if they have, like myself, have kids on the plan and need to take them into the doctor, knowing that, you know, stuff happens during cold and flu season, it's a $30 visit rather than today in that CDHP plan, right? You could be paying up to $150 for taking your kid to the doctor on a non-wellness visit. So we really have found with other states that had really encouraged HSAs and HRAs over the last decade, they're starting to move to a similar design as this new copay plan, trying to give employees better first dollar protection than they have today when they're on a high deductible plan. As Ms. Rich alluded to, yes, the deductible is out there, but because you have copays for the most common services, it really is important to emphasize that this is a copay plan. And that's really going to provide also a benefit when people are going to fill their prescriptions. It's a copay, it's a set amount, they know what they can expect to pay as they go to get those filled. So going back to the amounts on the screen here, so $61 for a single, $267 for the employee plus spouse, up to about $315 for the employee plus family coverage. And as you look at these amounts, it's also important to look over at what people on the EPO and HMO are paying today. Because of the way the plans have been underwritten and the spiraling that we've kind of seen when we've done the blending of the plans and the subsidies that have kind of gotten out of alignment over the past decade, people are paying quite a bit on the EPO and HMO plans. So as we're trying to restructure and offer 3 plan designs going forward with some decent separation in terms of the actuarial value that the plans are offering to participants, we're also trying to right the ship, if you will, and kind of get everything back to a more actuarial value alignment so that people are paying out of their pocket at time of payroll deductions, offsetting what they're saving when they go to the doctor on average throughout the year. So under this new scenario, and with all of these assumptions, the plan design 22 premium for the EPO HMO plan would be a savings of about $30 from what those members are paying today. It is still $80 more than the copay plan because you're certainly getting a richer plan on the EPO and the HMO, but you are still picking up some additional costs, but you're definitely seeing a savings from what you're paying today. Even more so when you're covering a family members, it's a $508 estimate right now for the plan year 22 premium versus the $690 that they're paying today. Of course, as we have that leveraging that occurs in plan year 23, there is a more sizable shift, but it's still below the current levels on the EPO and HMO plan. Some other assumptions that are important to note is that I have not put in any increase in admin fees. Certainly, as those items are out to bid, you may be paying more for, say, your Ben admin system in 22 and 23. Right now, I've just kept your admin fees constant for plan year 21 as I move it to 22 and 23. Yet another reason why these are certainly not going to be the final amounts that folks would pay if you would move to this structure, but definitely directionally, this is what you could expect to see. I think it's important to note, so if we are not so lucky to keep trends flat in 22 over 21, here is what that would look like if we did the 5% plan design change. So you're seeing no longer are you able to get the CDHP for the same price as you're getting it today. It's definitely putting upward pressure because the state subsidy has decreased by 5%. It's leveraging that cost back to the employee sooner than it was on the prior scenario where that leveraging didn't occur until plan year 23. So you're seeing a $60 cost for a single on the CDHP plan, a $78 cost to get to the copay plan, but you're still saving a little bit of money from today on the EPO and the HMO plan, but you will pay more than today when you get to plan year 23 for the EPO and the HMO as trend continues to rise and the state is keeping their contributions flat. Okay. Moving to the 10% plan design change. The 10% plan design change definitely puts you in a better position when it comes to plan year 23 cost, because it's accessing the ability to have more. That state subsidy is picking up a larger percentage of the cost because the cost have decreased overall by 10%. So today you're paying the $44 on CDHP. When you make plan design reductions, that brings total cost down by 10%, but the state subsidy only goes down by 5%. Now you're getting reverse leveraging and a benefit to employees. A benefit to employees is now they can pay even less because the state has picked up a larger portion when you've dropped the entire cost by 10%. So here it goes down to $12 for the CDHP under plan year 22. It'd be $34, which is still below what they're paying today on the CDHP for the new copay plan. And then it would be $120 on the EPO HMO. You still will get that bounce back up in plan year 23 as trends move things forward, but the state's amount stays flat, but it's still pretty darn close to really what you're paying today on the CDHP plan. Once again, this is a rosier scenario. We're hopeful that trends remain flat for 22 over 21, but if they did not, and let's say you saw a little bit of a trend, and I'm modeling 2.5% medical, 5% pharmacy, and 1.5% on dental to get these numbers. You certainly could see 5%. You could see 6%. It could go higher than this, but again, I didn't want to be overly the sky is falling, but I'm leaning more on the side of being a little rosy with these numbers. So here is again the 10% plan design change, but it's assuming a little bit of a trend happens for you all in 22 over 21. So instead of $12, it's $28. It's still a reduction from today. But then conversely, when we push trend forward one more year, again, that gets leveraged onto the back. So the employees share, and then that becomes a $58 rate on the CDHP plan. Conversely, for the copay, it could be offered at $50, so a slight increase from today. And then it becomes $82 when you move that forward to plan year 23. And I know that's a lot of numbers, so I will stop for any questions.
Hey, Stephanie, this is Laura Rich for the record. I just have a question. Is there any way that the plan can look at somehow adjusting the rates so that we can soften the blow in year 2 and there's not a shock to the system? Is there any way to kind of even them out from the first and the second year in the biennium, knowing that this is going to be, an issue?
Yes, for the record, Stephanie Messier with Aon, and that's a great question. So I think historically, that has not been PEB's path, but I don't think there's anything preventing you from taking a new approach. So I definitely think you've seen the impact of your 2-year budget cycle historically, right? You have a good year in the first year. The second year is set almost 3 years out in terms of the state subsidy. And so if your plan has a high claimant cost year, if you're no longer able to find those cost saving measures with different products, if you will, that you put into place, you see a really large bounce up for that second year. So something you might want to consider is knowing that it's going to change by, let's say, the leveraging because the state subsidy is staying constant. What you could do is try to artificially, or really just preemptively increasing plan year 22 by, let's say, another 10% on the employee side. That means you're going to probably generate a little bit of extra cash at the end of plan year 22, but knowing that you're going to put it only onto the employee portion. So it's really reallocating the state's money, knowing that it's going to stay flat for both years. It's charging the employees a little bit more, but you're giving it back to them in that second year so that they're not seeing such a large swing when it comes to their payroll changes. So for this example, you could probably say, let's say I want to hold rates at $40, so I'm charging $12 too much in the first plan year. It's not going to be the full 12 that you'll save on the back end, but it would be close. So this would maybe come down to 48. from 40, right? So then you're only changing it by $8 rather than right now, they're potentially going to be seeing a swing, which is basically almost double what they pay in plan year 22. Did that answer your question?
Yeah, it does. And for the record, this is Laura Rich. I just wanted to add to that. Consistency has been something that the legislature has been continuously counting, whether it's consistency on benefits, consistency on premiums. You know, this is something that's important. And I feel that it is also important because shocking employees in one way or another, you know, from year to year is just, it's not fair. It doesn't make sense. And
right.
So it's something that we need to start looking at as a program.
Yes, Stephanie Messier for the record, and I absolutely agree. I think especially because you have a biennial budget cycle, it's really not ideal to have to be going back to folks before plan year 23 to say, now we've got to change your deductible again. It also causes a lot of unknown plan usage when you have plan design changes mid budget cycle, if you will. And it's definitely unique to the state of Nevada. We have other states that are doing it annually, so it's a little bit easier to be able to get that increased money in the second plan year. But doesn't mean that we can't employ, you know, new strategies going forward that might help soften the blow and as you mentioned, create some more stability in what the employees are seeing from one year to the next. At least every 2 years, if you could keep those things constant, I think there's definitely an added benefit to doing so.
Marcia Urban for the record. These rates show a monthly of premium, but when you're looking at the modified CDHP, you're also looking at a drop in the HSA. So in the current one, it's $700, 5%, you're down to $500. So that's a $200 loss. And then in the 10%, there's no HSA. So even though it doesn't, you know, like, how do we look at that people are paying less, but they're losing this money from the HSA? So how do we reflect that so that they know when their rates are going up, but their HSA are going down? How do we show that and actually let them know that there's some support there?
So this is Stephanie Messier. I'm not sure how I can speak to the communication piece. I think probably Laura Rich can speak to that. But in terms of the change in the HSA funding, part of that comes about in terms of it's reducing the plan's overall cost. So it's helping them get to a lower paycheck amount because it's pulling down the total cost of the plan, and then again applying what the state is going to provide. So that way it saves. If we would go back and put a higher funding in there, that movement again just goes straight to the employees. So it's really the employees would then be paying for any additional money above the 500 to get, say, back to the 700. It gets put all the way back into their paycheck. So it's almost as if you're budgeting for that number for them.
And this is Laura Rich for the record. You are going to see if we introduce this this mid-level option, the copay option, you're going to see a significant portion of those on the CDHP move over to that copay option because it works better for them. That's going to be something that, you know, they appreciate and want to depend on the stability of, you know, the copay options versus the CDHP and co-insurance and meeting the deductible. And, you know, but then you're going to have the healthier population who doesn't use their benefits very often, and they're going to that CDHP. You're going to say, you know, this works for me. It's a lower premium. I don't go to the doctor very often. I don't anticipate going to the doctor. And I'm going to stick to the CDHP. So this just introduces more choice. That second plan or the new plan introduces more choice for members to really fit what option works for them best.
Marcia Urban for the record, if you look at the $700 that they would not be receiving of the HSA at a 10% decrease, then that really translates to a little over $58 a month if you use that as a monthly thing, and it's just and then the rates go up to almost $58 as well. So I just want to make that point.
This is Laura Freed for the record. May I ask a question about actuarial value and plan migration? Looking at the approximately 5% column on page 4 of the staff report, the modified CDHP has an actuarial value of 80.4%. The copay or the PPO has an 83% value, and then EPO HMO has 87.2%. These were designed to discourage adverse selection, were they not?
This is Stephanie Messier for the record. So part of it is we're also trying to give people meaningful choice, not just throwing plan designs out there to offer more plans, right? So we're really trying to delineate your current offerings, as well as secondarily, help soften some of the savings from the state giving you 5% less. The other thing that's a little bit more complicated when you're looking at actuarial values, the one thing to keep in mind is the EPO HMO plan has a certain actuarial value, but it also has no out-of-network benefit. So in terms of what the plan pays, it doesn't pay anything when you go out of network. So when we're trying to stratify back out your race, we're actually looking at what is the plan likely to pay based on the design and as well as the mix from in and out of network.
Okay. Laura Freed again, for the record. Ms. Rich mentioned that she expected a significant number of people to move from the CDHP to the PPO if it's introduced. How much, what's the definition of significant there?
So for the modeling that I did here, and I don't know if you can, are you able to see row 20 on the screen? I know I have a larger screen, so I don't know. Okay, so what I did here, and we used it based on our Aon Architect model that again has real world experience and data behind it to kind of say what have people done in the past? How are people behavior? How are they likely to perceive these different plans? And people are very focused on copays. Copays make people happier. Then they look at deductibles. Then they tend to look at out-of-pocket maximums, and then coinsurance is kind of one of the lesser things that they look at in terms of plan satisfaction. So, and I actually just did this with one of my other large state clients. They offered a copay plan for a slightly higher cost than their CDHP, and they did see about 50% movement at open enrollment in July of this year. So that's what I did on the HSA. I do think your HRA folks are probably a little stickier because when you leave an HSA, you still have that fund out there that you can use. But if you would move away from the HRA, my understanding, right, is that they're not able to take those dollars with them potentially. So they're more likely to stay in the HRA. So I only moved 25% of the HRA actives into the new copay plan. And then 85% of the HRA retirees, I left alone.
Okay, got it. Laura Freed again. So you just mentioned in sort of ranked order, participants care about copays, number 1, deductibles, number 2, and coinsurance down the list 3 or 4. Okay, got it. All right. So with that in mind, on the 5% column, and I'll stipulate here. I mean, under the current plan design, PEB can't make its $299 million per fiscal year of subsidy limitation cap that GFO has already placed on them. So that's why I'm discussing the minimum cut we could get away with in submitting an agency request budget in a month. So, okay, going back to what I said. Copays. I'm comparing copays, since that's topmost in participants' minds, statistically speaking, there's only about a 10 $10, $20 in some cases, okay, except for outpatient surgery, differentiation between the PPO copays, $30 versus $20 for a primary care, specialty $50 versus $40. ER visits, there's a differentiation. Inpatient, no hospital, no difference. A little bit of outpatient surgery difference. So I guess my question is, what would be attractive about the EPO when you have to pay higher premiums for, you know, relatively the same deductibles for the services people most often access?
Sorry, Stephanie Messier for the record. So what you see there is really the second element being deductibles. You do have people that are very sensitive to it, whether they recognize the fact that they may not be likely to hit the deductible. They're tied to that. You also have a group in the South with the HMO that I believe would lose their providers should they move to the middle plan. And I think that's going to be a lot of where they're very sticky.
Okay, got it. Okay, thank you.
Mm-hmm.
Board members, I'm not hearing a lot. Are we all stunned by the amount of information being presented today? I'm not hearing a lot of.
Yes, this is Tom Verducci for the record. You know, just a couple of thoughts here. I know we're just in the conceptual phase here, but it really would be nice to see the column in the middle plan complete so we could use it as a gauge in the future in terms of what the premiums would be today as opposed to the 5 and the 10%. I think we heard that from one of the advocacy groups earlier. Also, I did want to ask, do these changes that we're looking at in terms of the rates, do these incorporate the recommended policy changes that we see in item 10, or how would that affect these rates?
This is Stephanie Messier for the record. So my brain is best to remember your last question and I may forget your first. So in terms of your last question, yes, this does include all of those changes. I will say that the majority of them are really housekeeping and getting you to actuarial standards that are more widely adopted, I would say. So when it comes to like the admin fee, that's a net change. There's no dollar impact to moving to the new recommended method of PEPM versus the way it was being tiered out and applied today. There is a little bit of an impact in terms of the tiering, not much. And a lot of it's just kind of housekeeping cleanup items, I would say, the majority of items in number 10. The other thing that you're seeing in terms of a benefit from agenda item 10 is the pooling of your experience on the self-funded plan. That is why you're seeing a reduction on the EPO and HMO plan. It's modifying everybody's claims experience into one group, similarly to what you do with actives and retirees today, correct? You have everybody in the one group together. We all recognize that folks, as they get older, tend to need more services and definitely utilize more services. But you're underwriting everyone in a pool together. So that's really what is being included here. In terms of a total net impact, it's really kind of shifting money around in terms of that risk pool, but it's to the benefit of the EPO HMOs, kind of bringing them in line. And then the Southern HMO is no longer being so heavily negatively impacted by being blended with the EPO's experience. So that's kind of a positive that you're getting from agenda item 10. And then your first question, was showing that middle column. So for today's rate, so because you weren't offering the copay plan today, that's why that column in the previous spreadsheet was showing NAs. But if I go to your plan year 22 rates, and I take out the 5% plan design savings, and I put back the HSA contributions more closely to what they are today, as well as setting the state subsidy back to not being a 5% decrease. This is what those premiums would look like if you look at the gray columns. So it still would be going up if we did absolutely nothing. If you were able to still get 5% more in terms of the state subsidy amount tomorrow that you're getting today, and you didn't make any plan design changes, and there was no trend, this is the rates that you would be seeing. So $55, the copay plan would actually be cheaper because of the high level of HSA funding. This plan would now become a richer plan than the copay PPO. So you'd be able to offer the copay PPO at about a $36 rate. And then the EPO plan would be at about $112. If you actually saw a trend in plan year 22, we'll change that real fast. You can see here how impactful trend is when you keep the state dollar amount the same. And this is, again, assuming that the state is not going to cut your budget by 5%. The copay plan is $68, which is still higher than the 40 some dollars that the CDHP folks are paying today. But tomorrow, the CDHP folks would have to pay $85. So if the PEB board did not want to make a 5% plan design cut and was still lucky enough to get 5% more from the state than is currently being communicated, you would still see an increase on the CDHP plan, pretty sizable. That's more than double today's rates. Well, I guess it's a little bit under double. My math was bad. I apologize.
And, just as a follow-up, during the strategic planning session, we initially had a deductible, or excuse me, out-of-pocket cost up to $10,000, and we discussed what it would look like if we changed that to $9,000, and it did not seem like it was a real huge impact on those numbers. Would it be possible when these are presented again, perhaps to take a look at the out-of-pocket maximum from 10 down to 9? Or could you bring it up here?
I don't have the actuarial value model up. You're right, it is less because, again, if you think about the terms of the total percent of your population that hits their out-of-pocket max, and I'm not sure if Mary Catherine or Laura can correct me here, but I know it's less than 5% if I'm not mistaken, and I think it's even less than 3.5%. So it's a very small percentage of your population that hits that out-of-pocket maximum from one year to the next. So one of the other things too during that strategic planning session that we talked about is we're trying to keep people's total liability the same, regardless of which plan they pick, trying to really help protect the members. We don't want them to inadvertently pick the cheapest plan, but not realize that should they have a catastrophic event, that it could be a $15,000, for example, out-of-pocket max that I've seen on some other plans. So we were trying to be mindful of the fact that we have cuts to make, but trying to be fair and equitable where we could.
Okay, and the reason I'm pointing this out, we did hear public testimony from UNLV, Dr. Douglas Unger, and there was a disturbing story of somebody sleeping in their car, and the human aspects of individuals going from day-to-day expenses and dealing with pay cuts and furloughs. And it seems to me that there should be some motivation for the individual that's not really using their health insurance to save where they can in terms of out-of-pocket maximums and deductibles if it's not a huge impact on the program. And just going forward, like to see some choices as we get closer to the meeting.
Yep, this is Stephanie Messier. We certainly appreciate that, and we definitely understand the human element behind these numbers. But as you might imagine, the biggest levers PEB has to pull when they're looking for a 5% plan design change, the ones that are most impactful really are your deductible, your coinsurance, and then your out-of-pocket maximum. And that was definitely one of the places I wanted to touch last was the out-of-pocket maximum. But in order to get to the 5 and to the 10, those were numbers that we definitely, unfortunately, had to change. But certainly options that we can bring back in September.
Thank you.
Okay. This is Laura Freed. Board members, as I said earlier, the budget is due in a little bit over a month. And so Obviously, these are these rates and participant share amounts are pretty rough, and we don't know how trend might affect them. So I hope we don't hyper focus on that right now, and we talk fundamentally about plan design. So I'm going to throw it out to the board. Do you want to instruct PEB staff to submit an agency request budget in a month that contains a PPO middle tier option in order to give participants more plan choices?
This is Jennifer Kripp. I just wanted to ask one more question before we that. But looking at the middle tier with the new low deductible PPO with copay, I just wanted to ask you: are the copays for the primary care and specialist visits and things like that, are those expenses paid by members included in the deductible, or would those be separate?
This is Stephanie Messier. We currently have them as going toward the deductible.
Thank you.
This is Laura Freed again. So I want to say that I appreciate very much the strategic planning session we had earlier, and I appreciate so much the PEB staff and Aon's work in developing this scenario. I personally like the middle option of a PPO plan because those of us who are longtime state employees, and I think there's a lot of us, a lot of folks listening, remember that world before the CDHP was implemented in 2012. And it's a familiar world to participants. And we've been asked as a board, both while I've been on the board and numerous years previous, to provide more choice. So this provides more choice, maintains the Southern HMO for I know all our the Las Vegas employees and retirees like HPN, and allows those who aren't high consumers of medical costs to pay low premiums or low participant share, lower, and continue to accrue tax-free funds in a health savings account if they qualify for that. So I support this, and I'd like to hear what other board members think.
This is Jennifer Kripp. I agree, Laura, that this is a good option, and I do appreciate having additional options. I'm currently, just for disclosures purposes, I currently am on the CDHP program, but my children actually are on my husband's health insurance because, you know, he has an HMO. It's easier when you have to try and budget for costs and things like that. So the option that we're offering, where it's in the middle ground, or potentially offering, where some of these costs are a little more fixed, such as if your kid gets sick and you have to take them into the doctor, you know, knowing that's going to be a $30 copay, I think will be really, really helpful to a lot of our members, particularly a lot of our working ones who do have families. So I'm supportive of this as well.
Thank you. So go ahead, Mr. Verducci.
Yeah, Tom Verducci for the record. I just wanted to provide some input in terms of my thoughts here. I do think the middle plan here is very good. It's something that has been asked for. I'm very pleased that we're looking into it. The dental buy-up looks very, very interesting. You know, I think we need to continue looking at our financials, and as this comes up in future meetings, I'd like to see some choices in terms of pricing that's affordable. We have a lot of unknown variables with COVID going on right now. So far, hasn't been huge COVID expenses, and I think that going forward, this is something that I think would benefit the membership, and I think it's something that we should move forward with.
Okay. All right. So I think how I would like to structure this, sorry, Laura Freed for the record, is an up-down kind of a vote on include in the budget, a budget that accounts for the PPO middle option. That's number one. And number two, talking about the 5 and 10% reduction. I'm not hearing a lot of board member consternation about submitting a budget that includes the PPO option. So I would be happy to accept a motion that instructs the PEB staff to build such a budget.
Linda Fox, for the record, I would make that motion.
Okay, thank you. Do I have a second?
This is Jennifer Krupp. I'll second.
Great, thank you. Members, I think I'll do this one by voice vote because I don't know that I would need a roll call on this one. So all in favor, raise your hand or say aye.
Aye. Aye.
Any opposed? Thank you. Any opposed, nay? Okay, passes unanimously. Okay, so we will build, or PEB staff with Aon's assistance will build a budget for a submission to the GFO on August 31st that accounts for a PPO middle tier option. Now, moving to the 5 and 10%, the executive officer did a fine job explaining the concept of budget caps, which those of us in state agencies all have from the GFO. It was actually released March 19th, that all agency memo. That was, everybody was in the middle of COVID response at that point. So that agency memo really slipped by a lot of us, and we had to go back and look at it. So the PEB cap on the total amount of subsidies for the combined biennium of 22 and 23 is $598,174,098, otherwise known as about $299 million in subsidy dollars per fiscal year. And I asked PEB staff, and I want to note, by the way, that does not include caseload adjustments. So if there were increases associated with enrollment growth, that would be excluded from that cap. And trend is excluded from that cap. However, having said that, I discussed with PEB staff, could we get there? Could we submit an HC request budget under the current scenario and get under that $299 million in subsidies per year? And the answer is no. It's a resounding no. And you can see that if you go back to the current year expenditures in the financial officer's report. So I kind of thought I knew the answer, but I thought I'd have to ask it because I knew the board would be interested in that. So knowing that I'm sorry, Laura Rich has something to say.
Can I just interrupt you on that?
You may.
And given the current benefit structure, now we could, if we adjust the benefits, but that would be a much different conversation, right? So we would have to adjust the, the deductibles and the copays and the, we could do it just with additional reductions to benefit levels.
Okay, Laura Freed again. Okay, thank you for the clarification. But that itself represents a plan design change, much like what we are talking about here. to Mr. Verducci's comment about deductibles and out-of-pocket max, could we submit something without changing any of that? No. Okay. So knowing that, members, I want to suggest that we get away with submitting the smallest cut we can get away with to get under the mandated cap. And I think I heard Ms. Rich say that this approximately 5% column gets us under that cap. Is that correct?
For the record, Laura Rich, I believe it's correct, but I would like Stephanie from Aon to confirm.
Okay.
My mute was taking a while to get off. Sorry, Stephanie Messier. So yes, it's just a matter of how much does it then leverage to employees.
Okay. All right. So since the board makes policy decisions, we need to, the way I see the policy choice is, in order not to get, not for the PEB staff to get punished by the governor's finance office for bailing out on their cap, we need to submit an agency request budget predicated on that 5% column. However, we all know, I think Ms. Rich has indicated that the GFO will evaluate the economic forum. The economic forum happens in December, as you all know. They'll be looking at revenue projections all through the fall. And so they may decide to say, PEB, you need to cut your subsidies more. So do we as a board want to have that 10% in our back pocket to give to GFO or not? Knowing that the risk we run is that the GFO may decide to make cuts themselves sometime in the late fall, and the board and PEB staff might not like them. So I'm going to throw that policy question out to the board.
Marcia Urban for the record. I just want to, things have been moving so quickly and so many times there's no real specific comment on it. So it's a done deal that they're going, that the state in the 22 is going to be looking for cuts from PEB. I just want to verify that, right?
This is Laura Freed. Laura Rich, do you want to field that?
Sure. So this is Laura Rich. As far as we know, that is the only direction that we have been given to this point. And so, given the caveat that, there's been a lot that has been going on between the time that the direction was given to the time to today, and the pandemic and all the fiscal situations that have occurred after the fact, we have not received any other indication or any other direction, but that is the only thing we have to work with at this time.
This is Laura Freed. To that, I would add, from my perspective as a department head myself, coping with my own caps and my own possibility of additional cuts. To answer Member Urban's question the best way I know how, the cap is a done deal. Additional cuts beyond that are not necessarily a done deal. However, in my experience, the GFO makes these kinds of calls fairly last minute. So that leads to my question to the board. Do we want to have additional reductions in our back pocket that we're satisfied with? Or do we want to say, no, we're not going to do that and risk that they're going to go, that's enough. We've taken enough out of PEB.
Yeah, Tom Verducci for the record. I think the big question here is how it's really going to impact the premiums and the cost for the employees. And I always feel it's my responsibility to, especially, we're going through a pandemic, to try to submit a request that's going to have the least financial impact on the employee, that's within, budgetary constraints. And I don't think we should be asking for bigger cuts that might not be on the horizon.
Okay.
Jet Mitchell, for the record, I have consternation about 5%, 10%.
Right.
Because I am very aware and hear the advocates and the constituents discuss their personal stories, and those ring very true, and very saddened and burdened by those stories, and overlaying the fact that we're in a current pandemic. Having said that, I think it does make sense fiscally to submit the 5% and have that aligned with the additional 10% information, not to say that we're expecting that, but as an alternative proposal. In other words, cuts or changes on PEBS terms, not on other terms. But I do have consternation about 5%. I do have consternation about 10%. But I think with the current climate, I believe at least 5% seems like it will happen. I hope I'm wrong. I hope 10% doesn't happen. But in the free fall state that the state is in now, 10% is not realistic or more. And I would hate to have not presented something that has already been articulated and well thought out, that's on PEBS terms as opposed to other terms. So I do have high levels of heartburn and consternation, and don't want a 5% or drastically 10%, but I'm also aware of Stephanie's comments that constituents are very concerned with co-payments, out-of-pocket maximums, deductibles. Those things are incredibly near and dear to so many that I think making that smoothing effort, I think that makes sense to make it as smooth as possible, that although we are all in pain, to keep the pain as consistent as possible. So I like the idea of the middle option premium as discussed, and I like the idea of presenting 5%. I agree with Tom Verducci that we don't want to tell anyone that we want 10%, but I also think not having that information may make it appear that it wasn't thought through. So if there's a way to communicate that it was already thought through and articulated, I think that may help.
This is Laura Freed. I could not agree more with those comments, but I will say that if GFO is watching this meeting, the cat's out of the bag already.
But Paul Verducci, for the record, sometimes you give people a choice. You throw out 5% and 10%, and they look at the 10% and they say that works better in our budget. I like the idea of just submitting it at 5%, and if the financial condition in front of us gets worse, then 10% could be looked at later.
Okay, this is Laura Freed. Thank you. I think I'm hearing a consensus form for direction to PEB staff that the board seems to want to go ahead and, submit with the approx 5% roughly based on this kind of plan design, knowing that trend is up in the air, and then, if GFO comes back to Laura Rich and Carrie Eaton and says, nope, we need more, they'll kind of know what to do with that, rather than leaving it to folks who might be less familiar with the contours of the plan.
Jet Mitchell, for the record, I don't know if there's a way that Laura Rich and or others in PEB could include verbiage, or Carrie Eaton, or as appropriate, that says that 5%, this 10% is not what we want. It's not what we want to do. I don't know if there's a footnote that says something like, you're killing us. Some drastic very strong language. And I know our advocates are also being very vocal, and that's appreciated, to say this definitely has impact. These decisions are not being made in a vacuum, and these weigh heavily on all of us. So I don't know if there's a way to put the asterisk that says you're killing us, and to somehow articulate the level of pain and the level of consternation that it may be causing across the board.
This is Laura Rich for the record, Jet. I fully plan on having discussions with the governor's office, with the governor's finance office, and ensuring that everyone understands the effects of these decisions that we're making, and where the program is going, and what members, how members will be affected in the upcoming biennium based on this budget.
This is Laura Freed. Okay, so I think I would accept a motion based on the consensus I'm hearing emerge from the board to submit an agency request budget, for PEB to submit an agency request budget that comports to the approximate 5% reduction reflected in agenda item 9.
Linda Fox for the record. I'll make that motion.
Okay. Do I hear a second?
Well, Tom Verducci for the record. I'll go ahead and second that motion.
Thank you, Mr. Verducci. All in favor, signify by saying aye or waving in front of your video screen.
Aye.
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 This is Jennifer Kraft.
Jennifer, thank you so much. You're coming in late when I try to talk over you. Sorry about that. Any opposed, nay? Okay, motion carries. And with that, I feel sure that the PEB staff will bring back at this September board meeting both the submission for agency request, as well as what that looks like in plan design terms. So the members will not be kept in the dark about what that means, both in budgetary terms and what it means in plan design and hypothetical rate terms. So with that, we're going to move on to agenda item 10, discussion and possible actions of policy changes for plan year 2022. And I just want to note, for board members who have them easily at hand, I would suggest pulling out your duties, policies, and procedures document, because this staff report pertains to a number of the things that are articulated in policies and procedures that would change. So with that, I'll turn it over to PEB staff.
For the record, Laura Rich, and just to add on what Chair Freed said, I think discussions with her, I don't think it was clear that typically what we do with these policy decisions is the board makes the decisions are presented, the board makes the decisions, and then PEB staff comes back at a future meeting with the red line version of the new policies and procedures, and we the board approve that as well. So that's typically the process, and that is what we will do moving forward as well. So this really piggybacks on, again, the out of the May strategic planning meeting that we had regarding, where the program is at and what kind of policy changes can we make or should the program make to, to improve the program. And what it really boiled down to is that historically PEB has used a lot of calculations and processes that are outside of the norm of those of normal actuarial standards. And so what we've done is, you know, little by little, we've kind of baby stepped away from using, we employ an actuary to do the actuarial analysis of our program, yet little by little, we've kind of baby stepped away from using those actuarial standards and doing our own calculations. And the analogy I used for this was, it's kind of like asking your CPA to do your taxes for you, but then telling them to ignore certain tax laws or to change the tax laws so it works for you and submit your taxes based on that, right? So it's kind of like the same thing that we're doing within our program where, you know, we're asking actuaries to do their job, yet we've little by little changed what they do so that it's no longer an actuarial sound decision. And I think some of these decisions that we're presenting today will improve the program because one, it's going to clean up the budgets and the projections and things like that. And it's going to just make the program make better and sound decisions than what we're doing. And there's going to be more consistency and just overall better projections for the program. So I'm going to go over some of these. I have Stephanie from Aon also here to go into more detail on some of these policies that we're presenting, because I know some of it is, they're pretty complex. I think when you get down to it, it's not as complicated as it sounds, but she will go through and maybe, you know, give the details that a non-actuary like me can give. So the first one is underwriting the self-funded plans as one risk pool. The idea here is that the PEB plans, the self-funded PEB plans, so in this situation, it would be the EPO, the CDHP, and that new plan, the new middle level copay plan. They're basically a PEB member is a PEB member and a PEB claim is a PEB claim. It doesn't matter to us as a program what plan they're in, or it shouldn't matter what plan they're in. And so today, the way that we currently do it is we look at each of those plans separately, and they're looked at as a separate risk pool. And this policy is basically saying, you know, maybe we should look at underwriting all three of them together. And let me give an example as to why that benefits the program. So let's say you have a member, a high cost member who's, you know, let's say they've cost the program, they're on the CDHP and they've incurred $7 million worth of claims. That's a very significant cost to one member. And so that member's on the CDHP, and we ask Aon to go through and they price the plan out every year, right? We get the rates and they price that plan. That experience, that $7 million in experience is going to be taken into account when they price that CDHP. However, that member during open enrollment decides to change and goes to the EPO. And so we've got the CDHP priced according to that member's experience, but that member goes to another plan. And so then the next year, what happens is we raise those rates accordingly for the EPO, and then the CDHP rates go down, they're reduced because those high cost claims are no longer in that bucket. And so right now we have this inconsistency between plans because we're rating them separately. The reality is a PEB member is a PEB member is a PEB member. We are responsible for paying that claim regardless. So we shouldn't care where these members go. And in order to better stabilize the rates and better stabilize, you know, get that consistency within all of the plans, we neutralize that movement in the migration and those high cost claims by looking at them all as one single risk pool versus separate. So I'm going to stop. I'm going to do these one by one because I think it's easier to just discuss all of them, separately. But I'm going to give Stephanie the opportunity to kind of go in and maybe add to what I just said.
Thanks. This is Stephanie Messier with Aon, and Laura Rich did a great job of explaining this concept. The other thing I think I alluded to a little bit when we were on agenda item 9 is it's very similar to the methodology you're employing today when it comes to rating your actives versus your retirees. This is insurance. You are pooling those risks together. You do not want to adversely price the retirees higher, even though we all know they most likely are costing the plan more. We are consciously pooling those groups of folks together today. And this is just a continuation on that policy. It becomes even more important when you move to 3 different plans. The migration, again, of that one high-cost member going from the copay plan to the EPO to the CDHP. Now they have 3 different plans to choose from and go back and forth between. But again, if they're a self-insured member, they're PEB's responsibility. So it shouldn't really matter to PEB which plan that they're in. And so it really does, as Ms. Rich alluded to, increase the stability in your underwriting if you're underwriting all of your self-funded participants together, moving them forward with trend, and then parsing those rates back out based on an average expectation of what the plan pays based on the plan design for those 3 different plans. That way it no longer matters which plan that member selects at open enrollment. We've priced appropriately for your total claims in aggregate, and we've parsed back out the cost of the plan in terms of rates based upon the average design with which each of those different plans are representing.
Jet Mitchell, for the record, question for Stephanie: is it a fair assessment to say that a self-funded plan being underwritten as one risk pool is considered best practice from an actuarial standpoint, and doing it in the other way is not best practice? And allocating many different buckets and pools is not actuarial best practice. Would that be a fair assessment?
Stephanie Messier for the record. That's fair. As you know, the law of large numbers is definitely in play here. So the more that you have a large group together, the more stability that provides to your rate. So that's why it's considered to be the preferred approach. It's because you're enhancing your credibility of that plan by leaving all of those folks combined. The more you separate it out, and now when you move to 3 different designs, the credibility decreases, which means the volatility increases. So as actuaries, we're looking for ways to minimize that. So the more typical approach is to do one pool of underwriting, considering it's all your risk, and then to separate out the plans by, again, their designs in terms of what the people are expected to use based on copays and deductibles and those sorts of things.
Any other questions on this? Okay, so moving on to the second policy, which is the contribution strategy. So back in the day when the CDHP was originally introduced, the intent was to price the HMO and the CDHP plans so that the total out-of-pocket expenses, so that's the premiums and copays, they were equivalent. Over the past decade, this has not been maintained, though. We've, again, baby stepped our way into really preferring one plan over the other. And today, those HMO rates are quite higher than they really should be. The HMO participants are receiving a much less of the contribution than CDHP. So we are essentially preferring one plan over the other, when the reality should be that we should be agnostic to the plan choices. All of our plans, all of our self-funded plans are responsibility of PEB, and so it shouldn't matter what the member chooses. The way that we apply the contribution is really by a series of percentages, and we can mess with the percentages up and down, reduce them, increase them, and really, you know, we've worked ourselves to that situation where now we are preferring one plan over the other and pricing things out so that one plan is richer than the other, and really you're taking out the whole actuarial value of what Aon is doing when they develop those plans. And so this contribution strategy is basically recommending that we apply a flat dollar amount that is consistent across all plans. So for example, you know, if a plan is, let's say a plan is $900, one plan is $900, the other plan is $1,000, and the state is contributing $700. The employee is paying that differential. We're giving $700 regardless of what plan they're choosing. They are paying the difference of those plans because they're getting richer benefits. If they pay that extra, you know, $300 versus the $200, they're getting a richer benefit. And so under this new strategy, PEB's budget projections just become more stable, and it's no longer dependent on trying to guess where these members are going to land, if they're going to be in one plan or the other. And so it eliminates that variable when we're trying to project you know, for our budgets and just, you know, everything, whether it's enrollment, whether it's, you know, enrollment in each plan, or, you know, the budgets, any kind of projections that we're making. So Stephanie, I don't know if you want to add on this, and I know that there's been some questions regarding tiers and how that would be applied. So maybe you can go into a little bit more detail on the tiers.
Sure. So once again, Stephanie Messier for the record. So Ms. Rich, you've done a great job of explaining this concept as well. The other thing that this one kind of dovetails on the prior one is that you really have created a death spiral with today's practices in that EPO and HMO plan. And perhaps that was fine when both of them were fully insured, but you're really making it a non-viable option for the long term, whereas we all know the South does a good job of managing your costs. So it's been an unfortunate side effect of what's happened with the plan rates over time. So today, for example, PEB, I believe, saves $100 every time somebody moves out of the HMO or EPO plan, just because of the way the contributions are priced today. So again, as Ms. Rich alluded to, going forward, there's a lot more stability in budget setting when PEB is giving it $700 if you're in the HMO, if you're in the copay, if you're in the CDHP. They know that for any single that they're covering, it's $700. Now, there is still some volatility in terms of the tiers, but what we are proposing is when we move to just tiering in one different place, we're applying the same tier ratio when we do the subsidies strategy. So in Ms. Rich's example, so we know under the $299 million cap, let me switch over to my spreadsheet real quick. The state is essentially paying in aggregate about $735 per person, but that is a mix of the different tiers. So within that tier, we can set PEB's contribution strategy to apply the exact same tiers that we're using to set the rates. But today they give a little bit less to dependents. We can still do that going forward, but it's the same adjustment on each of the different tiers. So again, that way, I think we all saw it with, I believe it was an April board meeting when we were then trying to reallocate the money in terms of the increase folks were seeing among the different plans. And that's one of the instances in which we've gotten really sort of topsy-turvy in terms of actuarial practice and what it means to the members at the end of the day. This applies a lot more stability on a go-forward basis. And if it would help, I could bring up the spreadsheet so you can visually see the contributions from the state at the different levels. I see Chair Freed nodding her head, so I'm going to go ahead and do that for you all. Any questions as I'm bringing that up? Can everyone see my screen? Okay. So I realize there's a lot of numbers here, but I want to draw your attention to these boxes starting in row 14 and in column C. So here we have the different rates for the 3 different plans in column C, G, and K. And those are differentiated by the value that the people are getting in terms of the richness of the plan design. Here you'll see the state subsidy amount being applied, and you'll notice it's the exact same dollar to the penny for a single person. So again, here's what we were talking about. The state no longer will pay a different amount based on which plan you pick. It's going to give you $587. Doesn't matter which plan you're on. If you're covering a spouse, it's giving you $1,000. If you're covering a child, it's giving you $733. And if you're giving a family member, it's about $1,200. In order to try to equalize the percentages by the dependent subsidy amounts to be similar to what you had today, so we're not making too many changes and really getting illogical results, I'm applying about an 85% adjustment onto the tier ratios, and I don't want to get too technical here because I know I'll lose some folks in terms of creating the state subsidy. But the important point to note here is that the subsidy is the same, again, across whichever plan you're picking. You will note today, when we set rates, we do spouses are 2 times what an employee is, and you have the X plus Y for the child. So for children, it's a 0.4 factor. They're 40% of the cost of an adult, and the family is 2.4. But when you all apply subsidies, you give a little bit less because, again, PEB is focusing on giving money to the employees, right? Because they're the ones being employed by PEB. So you're getting a little bit different than those tiers when it comes to a subsidy amount. You'll notice here it's not quite 2 times the state subsidy of a single, but it's still a very good subsidy amount. Similar to what you offer today, but again, it's still applying consistency. There's transparency in how these rates are being set, and there's no longer this exercise of we need to apply different tiers, subsidy percentages in order to try to get a more equitable, if you will, false equitable changes in terms of a renewal from 1 year to the next. It's cleaner, there's better accountability, better transparency in this process moving forward.
This is Laura Freed. So just to solidify this in my brain, it is you're suggesting here a flat contribution by plan, but not by tier.
Correct.
In other words, okay. So, and we would get to, let me see. And so would we also then change the dependent subsidy formula that's been previously approved by the board, or is that not, or is that okay actuarially?
Good question, Stephanie Messier for the record. So it's okay, because when we get to the subsidy part, there really is no actuarial practice. It's very much specific client by client. Some clients actually want people to go into a certain plan, so they give more money to the plan. However, given you're a public entity and the other issues of budgeting and all those things, it's certainly more advantageous and more common to see a flat amount regardless of which plan they pick. And it's very typical to have different amounts based on which tier you're in. If you imagine the state only giving $735, this plan is then free. This plan is free. Basically, you then have free for singles. But if you're a single parent on the plan, you're now paying, much more going forward than you would be. Or if you have a spouse who's unable to work, out of pocket, you would be paying over $700 a month. And as you might imagine, state employees and the hardships that would cause, it's not ideal. So we don't typically see a flat amount by tier. It is usually tiered to have increasing subsidies as you get higher in the coverage.
Okay, so flat amount by plan, but subsidy. So it gets us away from the subsidy percentage discussions from a participant only standpoint, but not from the other coverage tier standpoint. I'm mostly saying this to, again, saying it out loud so I get it cemented in my head. Okay.
That's correct.
Okay.
Marcia Urban for the record. I'm trying to get this in my head as well. So this is what we do with the money after we get it from the state. Is that correct?
Yes, this is Stephanie Messier. You're correct. So you'll notice here this number. This number is what you're getting from the state, the 736 figure. When you roll that all up and apply it by the enrollment, you get to the $299 million we've been discussing earlier today. So it's really a matter of how you're allocating that across the tiers. So for example, if you wanted to only give 50% of the amount to dependents, it would change the amount that gets applied across these different amounts. And so it's giving less money to these other tiers. So it's really just a way of reallocating the state's money.
Okay, Marcia Urban for the record. So that means we get X amount of dollars from the state. This is how we're going to lay it out, and what the proposal is to make it an even rather than changing it percentage by percentage for each group. Just
that is
trying
correct.
to make it straight in my head. Okay, thank you.
Yeah, so today what you would see in these columns would be about a 550 figure here, and then on the HMO it's giving $650. So then you might imagine if you have 20% swing in enrollment at open enrollment, you're going to have a hard time hitting the state budget, because now you are giving $100 more for those folks that enrolled in the HMO and vice versa. And so that's where I think you've also seen a lot of volatility in terms of your excess cash over the years, is because of that movement, and because the state currently, the way the rates are set, is giving very significantly different amounts from one plan to the next.
Tom Verducci for the record. I just want to point out that I'm very supportive of this. I think that wherever we could even out what's being paid, applied to the member's account is going to get rid of discrimination between plans. And I do think the concept of it is a very good concept, and I'm very supportive of it.
Any more questions?
Marcia Urban for the record. Yes, I think giving people the same amount, employees the same amount is much better than playing around with different percentages. I've just seen so many numbers today. I'm like, I'm ready for a nap.
Well, this is actually, this is Laura Freed. This is actually a good, Member Urban raises a good point. We've been at this for over 3 hours. Does the board want to take a brief break?
No.
Oh, okay.
No.
No.
Let's get it done.
All right.
Let's get it done.
Okay, let's power through. All right.
I agree.
Chair Freed, I actually had one board member text me and ask, I didn't see the text in time, but it sounded like there was a request for a break.
Oh.
That's I just snuck away for a second, so we're fine.
Okay.
For the record.
I'm sorry. You got board members or PEB staff, if you need to take a break, please just, throw something at me, text-wise or in chat or whatever. Thank you.
Okay, so moving on to the next one is the HSA and HRA funding by dependent count. First of all, I want to say that we may not actually be in a fortunate enough position to even consider HSA and HRA funding this year. There's no promises on that, but at the same time, it's still something that we need to look at as a kind of a house cleaning or a housekeeping cleaning up effort in terms of budgeting and projections and kind of making everything more simple for the program. And so in this one, what we are proposing here is that right now we fund the HSA and HR contributions based on dependents. And so we do one funding for an employee, and then depending on how many dependents they have, we will contribute additional funding per dependent. This creates somewhat of a complexity and a projection nightmare, because we have to, from a PEP perspective, you have to basically guess how many dependents are going to be funded HSA and HRA funding this year. And so I think that the strategy here is just to make it more simple and have less of a guessing game and factor out that dependent number and look at maybe funding it in a much more simple way. And so there's 3 ideas here that I have been put on the table as far as different funding strategies. The first one is just a small change from what we do today, and that's really just funding it by tier. Are you an employee only? Are you on the employee plus spouse? Are you on the employee plus children or employee plus family? And rather than doing it by dependents, we're doing it by just the tier. So that's option number 1. Option number 2 is a single amount for employee only coverage and then another amount for a dependent coverage tier. So employees get X and employees and anything else get Y. So that's number 2. Number 3 is just a single amount. Let's just make it as simple as possible. You are an employee. This is what you get, regardless of if you have dependents. If you don't have dependents, you are an employee of the state of Nevada. You are a member of the PEP program, and this is what we are going to provide to you as a member, regardless of dependents. And I think, so option number 3 is obviously the most simple option, the one that allows PEB to make most accurate predictions and projections, and probably just the most simple version overall. Although I'm saying that, you know, there's definitely some politics behind all of these decisions. There was no recommendation, because I don't think there's a right or wrong in this recommendation. I think any of these will be a improvement to what we have today. I think that option number 1 is probably it's a baby step in the right direction, but a very small one. And then option 3 would be the most simple way to fund the HSA and HRA contributions and make those projections that much more sound. So I will stop there and see if there's any questions.
Yeah, Laura, Tom Verducci for the record. Could you remind me which one of these 3 options are we using today? Is that option 1, where it includes the spouse, children, and family?
For the record, Laura Rich, we are not using any of these options. They're the options on the table to consider today. The option, or that what we're doing today, is closest to option 1. Basically, the way we fund HSA and HRA contributions today is an employee gets a set amount, and then the dependents get a set amount. And so it just depends on how many dependents you have, up to 3 dependents on your plan. So it really just depends on how many dependents they have today. Does that make sense?
Yeah, it does. I'm trying to determine the difference between 1 and 2. It seems like the single on number 2, the single amount for employee only coverage, and you know, that also would include another dependent. So you know, could you maybe just speak to that, the difference of 1 and 2?
So for 1 and 2, for the record, Laura Rich. So the first one is by tier, right? So this is you get a certain amount for an employee only. You get a different amount for an employee plus spouse. You get a different amount for an employee plus children, regardless of how many children. And you get a different amount for employee plus family, regardless of how many dependents you have on your plan.
So would there be a maximum limit under 2? A maximum number of dependents?
Okay, so that's number 1. So on number 2, that the proposal here is a single amount for an employee and a different amount for an employee and anyone else that they have on their plan, regardless of what tier. So if they have any dependents, then it would be X for an employee, Y for an employee, plus whoever else they have on there.
And would 2 include a maximum number of dependents?
It would be, for the record, Laura Rich, it would be regardless of dependents because it wouldn't matter. It would be an employee by themselves and an employee with dependents, regardless of dependents, because you're not funding it per dependent. You're funding you're contributing that HSA funding by the tier.
Okay. And thank you. That's very helpful in understanding this. It seems to me that it would be best, that they should, indeed be receiving additional HSA, HRA funding. So that's just my thoughts.
This is Laura Freed. I have to say I like number 2. The reason being, it certainly instills more budget stability and dependability. I think the important thing to remember is the board just voted to submit an HC request budget with a PPO middle tier. And I would suspect that a lot of the people who are in the CDHP now who get both employee and dependent HSA contributions from the state would move over to the PPO. And I think, certainly Stephanie and can correct me with her actuarial expertise, but I think we'd see a lot of employee-only folks who are not great consumers of medical care and dental care stay on the CDHP, and those with dependents who could now count on copay stability, thereby easing their own individual budgeting, might leave anyway. And this might become more of if we, again, have the money to provide HSA, HRA contributions, this would become more of a thing for employee onlys. And as we all know, employee only tier is most of what the active participant group is. So I kind of like, I agree with Mr. Verducci that we should probably, provide a HSA, HRA contribution for dependents, but to provide dependability of budget projections while still maintaining a contribution for dependents. That's why I like number 2. Those are my thoughts.
So this is Stephanie Messier for the record, if I could just interject also. It's important to keep in mind the plan design going forward as well. So if you're a spouse or if you're in the family tier, you're still hitting the same deductible amount in aggregate and the same out-of-pocket maximum in aggregate. So in terms of giving people more HSA funding, if they're covering more folks, they still have the same deductible targets and the same family targets, regardless of how many dependents they're covering. So that's why we see a lot of people just give a set amount, regardless of which dependents you're covering, because the plan design is the same. It's just how many more people in your unit are collectively trying to reach deductibles and out-of-pocket maximums. But it's in terms of the group's out-of-pocket spend, right? It's still going to cap at the 5 and cap at the 10, regardless of whether you're covering 8 kids or you're covering 1.
This is Jennifer Fripp. I also had a really quick question too. So is these contributions would only apply to the CDPHP plan, correct? They wouldn't, if somebody signed up for the new mid-tier plan that we just approved to request, they wouldn't be eligible for this?
For the record, Laura Ritchie, you are correct. This is only for the high deductible plan.
Thank you.
Mitchell, for the record, I actually favor 3 because the majority of PEB participants are individual employee. I completely understand the comments made by Tom Verducci and Chair Freed regarding others covered. But since the majority of plan participants would fall in number 3, I think it makes sense to do a single amount per employee. The other benefit I think that having number 3 option would be if PEB is in a position where there's limited HSA contribution, it makes it mathematically easier to also divide that per employee regardless of tier, if we're in that situation for that plan year 22.
Yeah, Tom Verducci, once again, for the record. You know, the reason I kind of favor 1 or 2 is, you know, we are a family-centric program. And I do think that if employees have additional children, their costs go up, and this would provide them some relief. You know, just my thoughts as opposed to focusing on the group of people that are single.
This is Laura Freed. Should we move on to streamlining tier factors, or would you like to stop and choose one of these options? Throwing out to PEB staff or the board, whoever.
For the record, Laura Rich, I guess my original intent was to go through all these and then maybe one by one make motions and vote on each one of them separately after they were all discussed, if that works for the chair and the board. Yeah, okay. All right, so the next one is streamlining the tier factors. This is, again, one of those housekeeping type efforts to really improve, you know, the program and its projections and its budgets, and aligning ourselves with the actuarial practices or actuarial standard practices that is recommended by Aon. So the changes here, I know that the example or the explanation is a little complicated, but really the change is minimal. The way that we have been doing this is internally at PEB is we have what Aon provides to us as the base rate, right? Where they give us, they price the plans every year and say, this is what it's going to cost your plan. This is how you need to price your plan. And then PEB goes through, and what we do is we add an administrative load onto it. And that administrative load is full of just the cost to PEB, right? So we have PMPM fees for all kinds of contracts and programs and things like that, and just the cost of doing business. And so what PEB does is we take that lump sum and we just kind of add it on to each one of the plans based on where that administrative fee lands. And so what we are suggesting here is really streamlining, instead of this lump sum that we're just adding on and PEB just tacks onto each one of the plans, is really we're going to line item them out, and we're going to follow a more traditional actuarial underwriting by using the per participant per month factor for claims, also for the administrative fees, and 1 year or 1 tier for all plans and state and non-state. And then we're going to keep this factor, we're going to try to keep this factor static for at least a 2-year budget cycle. So I'm going to stop there, and I'm going to let Stephanie add to this as well, since this is, again, it's probably more complicated than we're making it sound, and maybe she might be able to explain it in a different way that may make sense to others versus what I just said. So Stephanie, why don't you take it away?
Okay, I'll do my best. So this is Stephanie Messier for the record. So again, as Ms. Rich alluded to previously, we would provide PEB with what we call the base rate cards. And what we were doing there was we were taking your claims experience, making plan design change adjustments if you had any that year, and then trending it forward to the plan year we were interested in rate setting. And then we would take a look to see how much did your spouses cost you, how much did your children cost you, and then we would tier out those rates based on your claims experience for both the states and then separately for the non-states. And then secondarily to that, we would take a look at your dental claims and we would go through the same practice. And as you might imagine, kids use dental differently than they use medical. Kids are actually much more expensive when it comes to covering kids on the dental plan than it is covering kids on the medical plan. So we would have a separate set of tier factors when we gave you the dental rates. So in the base rate card, we have now tiered your state medical and pharmacy rates at one set of factors. We've given you dental that's applying to both state and non-state by another set of tier factors. And then you have the non-state medical and pharmacy with another state of tier factors. Then you have HPN, who's giving you a whole another entire set of rates using what they prefer to be their tier factors. Then you mush it into making a sausage, basically. And the PEB rate sheet. And then you have yet another set of factors that Ms. Rich went through in terms of the admin fee. So at the end of the day, you're ending up with rates tiered at nothing that you can easily point back to and saying, this is our tier factors. It's now become a conglomerate of almost 5 or 6 different entry points of different tiers to create the final result. So again, in the effort of transparency, getting things much more clean, and then for PEB to be able to look back and say, where did our excess cash come from? There's just a lot of value in getting you on a more standard underwriting approach, which is let's move everything on a per employee basis. Let's take your claims and move it forward, project it, medical claims on a per employee basis. How much are we going to spend on pharmacy on a per employee basis? How much do we spend on dental on a per employee basis? How much do our admin cost on a per employee basis? Coming up with a total rate that's on a per employee basis, and then applying the tier factor then, and then you're done. It's a beautiful thing when you go the end just one time. Questions? I know it's complicated.
This is Laura Freed. Yeah, this was tough for me. And I haven't personally worked with that rates workbook. Okay, so one fundamental question. If you're converting all of your various admin contract costs to a per participant per month basis in order to add them onto the base rates, are we still having, as we have previously, various participant groups only paying for the admin costs that pertain to that coverage group? Or is everybody paying for a share of the total admin load for PEB, irrespective of their participant group or coverage tier?
Stephanie Messier for the record. So you have things in your admin today that are very specific to what plan they're in. A perfect example is the HSA admin fee. It is not fair for an HMO participant to pay for an administration of an HSA plan that they're not participating in. So going forward, we are going to apply a different PEPM by plan, only because in that instance that you're only going to be charged $2.50, let's say, per person for each person in that plan. So in the buildup of the rates, we're taking that into account, and we're saying, we know if you're on the copay plan, you're not going to cost us $2.50 because you're not in an HSA plan. You have it in a couple of other different areas, but overall, there's those general PEB, just cost of operating PEB, to have the PEB staff, to have the phone lines. That is going to be applied. Doesn't matter which plan you're in, everybody's sharing that, but you're right. A couple of different things that are very, very specific to a certain structure are getting applied to that structure only.
Okay, so it sounds like okay, so we're maintaining the same policy decision about which group pays for what, because you're right, most of the participants pay for most of the contracts, as well as the staff overhead, staff and other overhead costs. So, okay, got it. We're just converting the various units of measure, for lack of a better term, to a PEPM.
Correct, yeah.
Okay.
And I know you're familiar with the PEB sheet and probably other board members are not, but there was definitely so many places where you had to look to try to track things back. We're just trying to simplify that part of the process. But not overly changing the spend or anything like that. It's just keeping things clean.
Marcia Urban for the record. So just to clarify in my mind, what you're doing is you're taking all the administrative, how much it costs to run the thing, and you're splitting it up evenly. And if there's something that only pertains to one tier, one I don't know if you want to call it tier or group of things, then that charge will be split between them.
Stephanie Messier for the record. So yeah, it's very much plan specific, as you mentioned. So for example, you have case management on your self-insured plan, but you don't have it on the HMO. So we're not going to charge the HMO people for care management that they can't access. We're only going to charge it on the two plans that it would apply to, which is the copay plan and the CDHP plan. And then by tier, it gets tiered after that. So as you might imagine, if you have a spouse on the plan, you might be utilizing it at twice the amount of someone else who doesn't have two people needing utilization management or case management. So it gets tiered after that step, rather than before it was getting tiered at multiple places. So there was, again, multiple different areas where the tiers were being applied, and we're just trying to streamline it before then, differentiate it by plan if it needs to be, because again, certain things are not getting utilized by certain folks. And then it's applying a tier after that, just one time, rather than 5 different places.
Okay, Marcia Urban for the record, thank you for the clarification.
Yep, great question.
Okay, anything else on that one? Okay. So I'll move on to the next one, excess reserves. This is one I wish we could skip. So excess reserves. This has been something that I think the board really needs to, to develop a policy on. And it's my opinion that the board should develop a policy on because of the long-standing issues and arguments we've had regarding excess reserves. In the past, it's, what defines what is an excess reserve and how do we use the excess reserves? And so I think since there has been nothing in policy regarding any of this, it's probably time that the board takes up this topic and has at least some initial discussions, if not some final policies that we come out with. So one of the things that we've discussed is defining what is an excess reserve. And during strategic planning, we did talk about this topic quite a bit at length. And I think that the calling it a reserve is probably not the right terminology because it really isn't a reserve. What it is it's excess cash. Ultimately, it is your revenue minus your expenditures equals what is excess. That's either excess cash or a deficit, right? You're going to end up with one or the other. And so I think calling it excess cash changes the language and the terminology and really identifies it as what it is. So the first recommendation here is let's refer to it as to what it is. It's excess cash. The second thing that we want to talk about is, when are we going to identify what this excess cash is? Those of you who have been on the board for a while, and definitely a lot of the advocates who come up to public comment, they've seen the budget reports. We have seen that throughout, at least the last several years, since I've been at PEB, projections for at the time, excess reserves, they were up one month, down another month. You'll go from, 20 million to 1 million, back to 50 million, and they're just kind of up, down, up, down, up, down. And we want to identify a point in time that we think this is the most sound, when it is no longer, because it's always a projection, but when is it not really a projection? When is the best time to identify a point in time to identify when this is actually excess cash to the program? And so what we are recommending here is that PEB reports excess cash in September. That is a point in time where we feel that, it's the end of the fiscal year, end of the fiscal year is passed and closed. And it's the time when the most sound and consistent figures can be reported. And it's more on an actual basis versus a projection, because the rest of the year, we're really working on projections. And not to say that in September, it's not a projection, because there is a component to that, but it's the best time to say, this is what we think is that the program has in excess cash. And so that's the first part of it. The second part of it is, what do we use this for? What is it appropriate for the program to use this excess cash for? This is something that I think the board should discuss and develop a policy on. How should the program use this excess cash? In my opinion, I think it is probably it's a better decision to talk about what we don't think it is suitable to use for. So for example, ongoing costs of the program, rather than pigeonholing the program and saying, this is the only thing we can use it for. I think we need to start the discussions of what is definitely inappropriate to use the excess cash once a year that is reported. What is it inappropriate to use it for? And maybe what is it appropriate to be used for? This one, the recommendation was fairly broad, because I think it really necessitates a conversation and discussion by the board, and maybe just a deeper dive into it. So there was no real specific recommendation by PEB. So I'll stop right there.
Jet Mitchell, for the record, I think the verbiage may matter on how we label this line item, and maybe instead of calling it something that has the word excess, maybe just calling it differential amount. Because if the differential amount is positive, that by definition means it's more, it's in excess. If the differential amount is a negative amount, it's a negative differential. So I know we're not doing any deliberation, but my comment is it may make it add more color around what is happening with that amount, to call it cash differential or differential amount, so that it isn't automatically labeled as an excess, and it's not automatically labeled as a deficit. It's differential. What is the difference? Because that also encompasses the definition you just gave. What is the difference? And then that's identified in that line item. And I know that's oversimplifying as far as when and where and what, but just as far as verbiage to start with, I think we should call it differential amount, because it doesn't denote a positive amount or negative. It's a neutral language.
Yeah, Tom Verducci for the record. I think part of the problems we've been running into for the last several years that I've been involved on with the board is that, as Jet was saying, the word excess seems like it's extra. And I think if you can get rid of the word excess and something more in line with what Jet was pointing out, the differential account or positive or negative cash flow, positive or negative cash on hand, and we can even come up with an acronym. Say positive or negative cash on hand could be the PNCH account. But I'm leaning towards what Jed had brought up there, towards differential account. The word excess, we're going to be approached from individuals that are going to say that's extra and you should spend it. And we're going to get our hands slapped again in the future. Or perhaps spending it on ongoing expenditures in the program.
Yeah, Madam Chair.
Yes, Mr.
Madam
Bailey,
Chair.
please. Yeah.
For the
Please
record,
go ahead,
Don
jump right
Bailey.
in. Go ahead.
Am I on?
Yes.
Madam Chair,
Yes.
this is for the record, Don Bailey. Hello?
Go ahead.
Yeah, I have to agree with Tom. The wording has to be, I think we have to take a look at the wording on access and cash. In the past, numerous times, we've been raked over the coal for the way the board used it, the way we got it, and our fellow members even question excess revenue, and how we used it. So the legislature, I think in the last one before this one, made some changes that we have to follow now. Is that correct? I can ask Laura on that one. I think we have to go to the advisory board now, and we have to go back to the legislature on using the excess funds. So, Laura, maybe you can bring us up to speed on that.
So Laura Rich, for the record, yes, you're correct, Don. So when between sessions, if there are any major benefit design decisions by the board, they must be brought to the interim finance committee. And PEB has been doing that. We've been presenting at IFC just so that they are aware. Sometimes it's informational items, sometimes it is items that will require their input. But yes, you are correct.
So I guess I caution the board on taking a real hard look at this and how what wording we use, agreeing with Tom and the chair, what kind of wording we use. I think it needs a little more scrutiny on that particular item.
This is Laura Freed. Okay, thank you. I think the board's, sounds like the board's fairly all agreed that the use of the term excess reserve is probably not the best idea. Personally, I'm agnostic as to whether we call it differential amount or we call it year-ending cash on hand or something else a little bit more anodyne. My question centers around when we report it, as opposed to when we might use it or not use it. I think it's certainly fair for PEB staff to say, we'll report differential cash remaining from a fiscal year just ended at the September meeting, because then the fiscal year will have closed. And that's pretty coincident with, to Mr. Bailey's point, the new changes to the law that the legislature made in 2019 that basically say if you're going to use any of that cash in change plan design, it has to go to IFC. And when you adjust your reserves, you must do a work program for that, because PEB got dinged because any actuarial adjustments to IBNR or catastrophic or any necessary reserves, or any necessary changes to HRA reserve they were carried by the financial officer, you know, on the books, if you will, but they were not reflected in the state accounting system. And so the legislature changed that. So, I mean, I think it's a good idea to report your cash remaining when you're doing that work program as necessary. But the question is, the board generally makes plan design decisions in March at every rate setting meeting. So is PEB staff suggesting that we kind of sit on that cash until the next rate setting meeting and then determine what, if anything, to do with it, or what?
Record, Laura Rich. So this is that's part of option 2, the second part of that decision, right? So how do we use it? We are identifying it in September, and generally in November is when we sit down to talk about plan design decisions, right? So this is where the board should take a stance on, is there anything that should be off the table? What is not appropriate? So for example, let's say that we have $5 million in, we're calling it differential now. So let's say we have $5 million in excess differential. And so is it appropriate to take that $5 million and decide that for 2 years, we're going to fund a benefit that is going to cost the plan $5 million? We know that we cannot continue that benefit, or there's nothing to say that that benefit will continue beyond those 2 years. So is that appropriate? Is that something that the board thinks is appropriate to use excess differentials for, or is it maybe something that is not appropriate? So there's just decisions like that need to be considered and that need to really be discussed, because in the past, this has been a really hot topic and something that not just the board, but the advocates and members, you know, there's a lot of different opinions on this. And I think that this is something that the legislature has taken up, and the governor's finance office. I think all the stakeholders have really been a part of these discussions and decisions. And I think everyone sits on a different, they have a different opinion. So I think this is something that the board needs to really take up and identify as to where should the program, if there's some extra money laying around at the end of the year, what should it be used for? What is the appropriate use for this? And there's some ideas on the table we can talk about. You know, I just used one example of using it for a short-term benefit. Then there's another example of maybe a premium holiday for members. That's how we could give back the money. Mm-hmm. I don't know if it's the right move to pigeonhole ourselves into what do we use the money for. I think it's a better decision to really talk about what is not appropriate and what should we not even consider, and decisions that the board is not going to bring to the table because they will negatively affect the program, affect members, or maybe it's just not something that the legislature has an appetite for. So I think that's kind of the direction I'm trying to head.
So, Laura, Tom Verducci for the record. I like the idea of September being the date that we look at the balance there. And, you know, if you look at the history on the excess reserves, it used to be a really big number, and we really did not have any sort of guidance. And I think that we've gone towards the direction of recommending those funds be used for one-time expenditures and not the ongoing expenditures. But I do have a question. If we make a recommendation to use those funds, does that have to go before the IFC and the governor's finance office? Is that correct? I believe that is the answer, that we can make a suggestion or recommendation, but the ultimate decision on that does lie on IFC and GFO.
For the record, Laura Rich, Tom, you hit on two things actually. So the answer to your question is if we are between legislative sessions, and yes, if it's a benefit, if the money is being used for benefits, then yes, that requires an approval by the interim finance committee. The other thing that you touched on was in the past, this was a big bucket. There was, we're talking, $100 million, right? We don't anticipate, and especially after making a lot of these policy changes that are being recommended today, we're hoping that that number is no longer, $100 million. We're hoping that the discussion is closer to a few million in one way or the other, right? Hopefully a few million in excess versus a deficit. But the goal of today in changing these policies is to better get us to a place where we can make better projections and budget more effectively. So in the future, we're not expecting this to be $100 million question. It's going to be a much, much smaller number. So we're not talking about the big numbers we were in the past.
Yes, and in the past, I mean, this would even show up in local newspapers, and there was a lot of pressure given, put on the executive director of PEB at the time that I read about. And it seems like that if we have a reasonable flow on this account, and it's not always building up, it shouldn't be an issue in the future. But if it does have additional expenses, reserves coming in, and rightfully so we should put recommendation into the government, GFO and IFC, and if our rules are one-time expenditures as opposed to ongoing, where we're going to show artificial premiums, so be it. It could even be a rebate in premiums, a holiday expenditure. I'm on board with everything you've said there.
This is Laura Freed. I feel like I agree with Tom's comments. The board's gotten beaten up by the public, the participants, certainly the legislature and the budget and fiscal staff. And I'm guilty of it myself. Look at I'm me. So I'll own it. I could not agree more that we should probably put into board policy that if we have excess cash, or not calling it excess cash, whatever you guys decide to call it, when it's officially reported, that we should specify that it should be used for one-time expenditures, not things that are ongoing costs of the plan. Because the danger there is we could enrich the plan design a little bit, and then the people who use that and enjoy it lose it in the next biennium or the next fiscal year, even if we have a bad claims year. And then we're back in trouble with some subset of the participant, and I don't want to be there. And so I think we get into if we just have a few $1 million in differential cash at the close of a fiscal year, that's not going to buy you much in terms of enriching a plan design anyway. So if we get where we need to be, and in a $500 million budget, a couple $1 million is just not that much. So that's within the realm of reasonable for cash left over. It would serve the board and PEB staff to find kind of small dollar, relatively speaking, one-time benefits that can be provided. And I'm not in tune enough with plan design costs to know what those might be, but that's my suggestion. Because a plan like a true rate holiday where the subsidy is not paid and the employee premium is not paid and the board or the existing cash in the plan absorbs 1 month of costs, that's a pretty expensive prospect, but it's a great way to liquidate cash that's not needed, just as an example. So that's why I suggest if we're getting better at our projections and we have just a few $1 million to use, what can we do with a few $1 million is something we need to think about. But again, I'm totally on board with policy that says we don't use differential cash for ongoing costs of the plan.
Yeah, Madam Chair. For the record, Tom Bailey.
Go ahead, Mr. Bailey.
I totally agree with what you're saying. I only raised a red flag just to be a little cautious because some of the people on the board have been through this before numerous times. And really, the executive director usually took some pretty heavy flack over to LCB. And I would not like to see that happen. And I would like not the board to be responsible. I think the best way was what their policy change is, and I'm all for this policy change. I always have been on that cash thing, but lay it out in black and white. Maybe even put an amount on it that could be carried forward. Certainly not $80 million or $70 million. We have reached them high numbers. And at that time, the board decided we've actually made some dental changes. We made all kinds of things, which probably is not really the sound way to go. So I think what Laura wants us to do is probably help them put together what could we do and what we should not do. So I'm all for the policy change. Thank you.
Thank you.
Deb Mitchell, for the record, I agree with the comments that have been made. And for the reasons that they've been made, I would also add, if the differential is a positive amount, I would overlay the environment we're currently in and maybe have some verbiage that says, barring emergency situations, this is the plan, or barring exigent factors, because the situation we're in now is that the differential may be a negative differential, or the differential may be positive, but with the view of a tsunami of claims from former claim suppression. So the funds wouldn't be used because of that emergency situation. So that's the only comment I would add, is some verbiage that would say, these are some guidelines. This is, we know we won't use it for ongoing costs. We know we will use it for this, or this, or one-off benefits, barring emergency situations, because if there is a differential, but we're seeing the freight train in the horizon that we need to factor in.
Right. This is Laura Freed. You're absolutely right. We're sitting on a few million more, we think, to close out FY20 because of claim suppression. And so, Stephanie could add more color to how much that claim suppression is going to last through FY21, and to what extent that boomerangs back on us in future claims costs. And so is it wise to use the differential cash? Because we may have a whole bunch of pent up demand for procedures that people just haven't had done this plan year or last plan year. And so we might need that money later. So it's, I agree that there's got to be some provision for fiscal emergency of some kind. Anyway. Again, this is Laura Freed. Board members, are there anybody who hasn't spoken up have some significant feelings to share about the idea of what we call excess cash and what we do or do not do with it as a matter of board policy?
Madam Chair, Tom Verducci. I really like the name differential cash. I think we need to get rid of that word excess. It's going to be out there to the public, and we're going to get continual requests to spend that down. I think it's at a reasonable level where it's not a highly contested issue as it was a few years ago. It should be a reasonable balance in that account. And I think if we see it growing, we do need to find a way of having it dispersed properly, not going into ongoing expenses. So I'd like to see the term changed to a differential account or differential cash.
Okay, thank you. Ms. Rich, did you want to end it there? Did you want to go on to RX rebates?
Great, let's wrap it up. I will, for the record, Laura Rich, I will wrap it up with prescription pharmacy rebates. So this isn't necessarily a board decision. It is something, it's a significant change though, so I wanted to bring it out there and make sure that that it is public. In the past, what we have done, and you've heard advocates talk about this, you have heard staff also talk about it, the pharmacy rebates they're significant. Right now, we're looking at approximately $13 million in rebates to the program. And so when they come in, we actually have them today offsetting administrative accounts, right? So those fees. The reality is they should offset claims. And so we're making that change moving forward in this new budget, or we're recommending that change moving forward in this new budget to really just change the categories and have pharmacy rebates offset claims versus admin fees as really they should and makes logical sense to do. So that really just provides a more accurate reflection of the underwriting of claims calculations as well. Any questions on that?
Madam Chair, for the record, Don Bailey, on the rebates, I would continue giving PIB the go ahead on that. And I like the part where you're going to be working with the governor's finance office. I think that's a very good move, and they'll know what's going on with the rebates.
Okay, thank you. This is Laura Freed again. Okay, so now that staff has gone through all of the topics that they wanted to cover in agenda item 10, did you want to take these one at a time? I mean, this is an action item, so I assume here that we would need to move to approve the suggestions, not necessarily, because there are, oh, I'm sorry, I take that back. Page 3, there are recommendations 1, 2, 3, 4, and 5. But within that, there are there are some specifics, because on HSA HRA funding recommendation number 3, there's no specific recommendation for the dependents. And on number 5, excess reserves, I think we need to, it's not a accept staff recommendation, because we have some thoughts about calling it differential funding, and we have some policy direction to give to the staff. So let me start then. I guess I've just talked myself into it, taking these one by one. So on underwriting all self-funded plans into one risk pool, but keeping the state and non-state risk pools separate in conformance with statute, do I have a motion to accept staff's recommendation?
Linda Fox, for the record, I'll make that motion.
Thank you. Do I have a second?
David Smith, for the record, Madam Chair. Go ahead.
I heard Mr. Smith speak first, so I'll accept Mr. Smith's second.
Oh, okay.
I'll let you have a crack at it in a minute, Mr. Bailey. All those in favor on number 1, please signify by saying aye or raising your hand on your video screen.
Aye. Aye.
Aye.
Any opposed, say nay. Okay, that passes. Number 2, apply a single contribution strategy across all plans. So you all saw Stephanie's spreadsheet with the illustration of what it would look like to have a level contribution across all plan choices. Does anybody want to approve staff's recommendation? And if so, I'll accept a motion.
Tom Verducci,
Linda Fox, for the record, I'll make that motion.
Yeah.
Mr. Verducci, is that a second?
Yes, that would be a second. Tom Verducci, for the record.
Okay, great. All in favor, signify by saying aye.
Aye.
Aye. Any opposed, say no. Okay, thank you. That passes. All right, number 3. So we had I heard a little bit of divergence of opinion on HSA and HRA funding. Again, provided we have the money in the budget to actually provide a contribution. Between number 1, based on tier, employee plus spouse, employee plus child or children, employee plus family. Number 2, a single amount for employee only coverage and another single amount for any of the dependent tiers. Or number 3, single amount per employee, regardless of tier. I wanted to get the sense of the board, and anybody who wants to move to approve any one of those things, please feel free.
So Linda Fox, for the record, my motion would be that we approve number 3,
Number
single
3
amount per employee, regardless
okay.
of tier.
All right.
Yeah, Tom Verducci, for the record, I just wanted to have a discussion on this.
All right.
I don't have a real good grasp on this one. I want to make sure that the decision that we're making supports the families. Everything I'm reading is that our plan has become family centric, and I want to make sure that the employees that have spouses and children have adequate funding for the medical expenses. And
Okay.
I'm not sure if we go with item 3, if it's going to be one single amount that goes just to the employee themselves, regardless of their family. So
Yeah,
it's discussion only, and
understood. Okay. So let me, now that, well, Vice Chair Fox has moved adoption of number 3. So let me see if I can hear a second for that.
Jet Mitchell, for the record, I will second number 3.
Okay. All right, then knowing, okay, option 3 is the one on the table, which is a single amount per employee, regardless of whether that employee has dependents and is enrolled in any of the dependent coverage tiers or not. So with that, all in favor, signify by saying aye.
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 Okay, this one. Oops, I think I better do a roll call. Sorry about that, guys. So, Vice Chair Fox?
Yeah.
I'm just, okay. Mr. Bailey?
No.
Okay. Ms. Urban?
Yeah, aye.
Aye, okay. Ms. Mitchell?
Aye.
Mr. Smith? Mr. Smith? Still with us?
Aye, sorry,
Okay.
you cut out. Didn't hear my
Sorry.
name.
Mr. Verducci?
no.
Okay. Ms. Krupp?
No.
Okay, so 1, 2, 3, 4, 1, 2, 3. Oh man, I have to abstain because otherwise we're deadlock. All right, we have 4 ayes and 3 noes. And I was going to vote no, and I don't think I should because this is not this is enough of a thing. So that motion fails, unfortunately. So going back to the idea of providing some kind of subsidy for dependents and yet providing budget and projection stability for PEB staff to project, claims costs and spend. I heard some support for option 2. And Mr. Verducci, I think, if I remember, was having a sort of a bit of a struggle between number 1 and number 2. So what's the sense of the board between those 2 ideas, number 1 and number 2?
This is Jennifer Crook for the record. My sense would be that I think that number 2 would be the best choice.
Okay.
Madam Chair, Tom Verducci, I'm on board with number 2 as well.
Okay. All right. Is anyone willing to move approval of number 2? Single amount for employee only coverage and another single amount for any dependent coverage tier.
Madam Chair, for the record, Don Bailey, I so move number 2.
All right. Thank you, Mr. Bailey. Do I have a second?
Jennifer Crook for the record, I'll second.
Thank you. All right. I'm going to do another roll call. Ms. Fox?
So I need to ask a question.
Okay.
Do I need
Great.
to vote for 1 or 2 at this point?
The motion on the table would be number 2. Approve number 2. A single amount for employee only coverage and another single amount for any dependent coverage tier.
So I guess I'm a no.
Okay. Mr. Bailey?
Yes.
Ms. Urban?
Yes.
Ms. Mitchell?
No.
Okay. Mr. Smith?
And for clarification, this means that if you are, if you have one dependent, whether it be spouse or child, it would be the same rate. That's correct?
Correct. It would be the same contribution.
Yeah, my vote is no.
All right. Mr. Verducci,
Yes.
Ms. Krupp.
Yes.
Okay. All right, that motion carries. Because we had 4 yays and 3 nays. Again, the chair abstains, trying to stay out of this. Okay, thank you, everybody. I know that was a little bit of a difficult one. Streamlining tier factors. Okay, so this is the one basically about admin load, taking that base rate card that Aon has typically provided or always provided, and the way that they load the administrative costs of running PEB and maintaining all of its contracts. So what is the sense of the board? I'll just say it. I think it's a good idea. I'm particularly compelled by the idea that we could track back to where we are gaining or losing money. So the idea of being able to provide a little bit more of a forensic look at how the plan got to the financial shape it's in is appealing to me.
Well, yeah, Tom Verducci, for the record, I think we, on this one, we make a motion to approve item
Okay.
number 4 as written here.
Okay.
For the record, Don Bailey, I second that motion.
Okay. All right, so the motion on the floor is to accept the staff recommendation to accept streamlining the tiers by following a more traditional actuarial underwriting process by using a per participant per month factor for claims, adding on admin fees per participant per month basis, use one tier for all plans, products, state and non-state, keeping this factor static for a 2-year budget cycle at a minimum. All those in favor, please signify by saying aye.
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 Aye. Any opposed, no? Okay, that one passes. Okay, number 5. What do we term any cash remaining at the close of a fiscal year? And how should we establish a board policy for what to do or not do with it?
Yes, Madam Chair.
Yeah.
Tom Verducci. I think the wording on this would be that the excess reserve should be defined as the differential cash account and only used for one-time expenses. And it's not a motion, but my thoughts, and I just want to make sure, if there's other input, I'd like to see if I'm actually hitting the nail on the head here or missing something.
Jeb Mitchell, for the record, I think the only thing that you were missing, Tom, was the approximate date that the board wanted to make that, excuse me, make that determination. And the only thing that I would add to your verbiage on the differential would be to say barring emergency situation or barring emergency circumstances, just to keep that wiggle room open for unprecedented times in which we are in.
Got it. Yeah, Tom Verducci, just to dovetail on your thoughts there. So if we add the September 30th and the language that Dr. Jet Mitchell had provided here, with barring, how did you say that, unusual circumstances?
Jet Mitchell, for the record, I used the words barring emergency situations or barring an emergency circumstance or barring exigent circumstances or something to that effect. I don't care how that exact
Got
verbiage.
it. So, Tom Verducci, once again, I think the way the motion reads on this one would be that excess reserves should be defined as the differential cash account only used for one-time expenses reassessed September 30th, barring emergency circumstances. And I'll put that forward as a motion.
This is David Smith, and I'll second that.
Okay, thank you. I have a question on the motion. What's the definition of an emergency circumstance here?
Jet Mitchell, for the record, the reason I said the verbiage emergency circumstance was by nature, it is a highly unusual situation, like a global pandemic. Like,
okay.
Verbiage to Tom Verducci's motion could be verbiage including emergency circumstances, which in the past have included events like a global pandemic. So it could be an example given of what an emergency circumstance were or is, or just barring an emergency circumstance, because I think it's like that whole we'll kind of know it when we're in it situation, because assuming we wouldn't be in it otherwise. Most times are not emergency situations or special circumstances. So it would be very unusual and unique circumstances. And you're wanting to have a little bit more color around it.
Yeah.
Madam Chair?
Yes, Mr. Smith.
Yeah, no, I think that the board can define it at the time. I think that the motion is based on, it's a one-shot use when, if it's something appropriate, but if something comes up that is unforeseen and the board needs to apply it to something, that would be, I think that would be an emergency circumstance. But I think the board can define it at the time if something comes up.
Okay. All right. All right. So we have a motion and a second. I'm almost scared to try and repeat this one. To stop me if I'm wrong, because I've already made one mistake, and I'll go back to that in a second. Okay. The motion on the table is to refer to excess reserves as differential amount and to establish it on at a point in time, and this motion specifies September 30th, and to utilize the differential amount, if it's positive, for things that are not ongoing expenses of the plan, subject to possible emergency circumstances that the board might define. Is that a correct restatement of the motion on the floor based on its maker?
Bill, Madam Chair, the only thing that was different here is I didn't mention a differential cash account. I think
differential cash account. Okay.
Yeah, just differential amount. I think we do need to get the word cash in there. And, if it's a one-time expense, I don't really see why it has to have that wording in there, barring emergency circumstances, because the funds would still be used for a one-time expense. But I'm good with that either way. I don't want to make it too complicated.
Chair Freed, this is Carrie Eaton from the record.
Hi, Carrie.
To clarify, I think the date should actually be August 31st, and we would bring it to the board in September.
All right. So does the member who made the motion agree to that amendment?
Tom Verducci, for the record, yes, so be it.
Okay. Okay. You heard the motion on the floor. I'm going to do a roll call on this one. And this time I promise to count it right. Vice Chair Fox.
Yes.
Okay. Mr. Bailey.
Yes.
Ms. Urban,
Yes.
Ms. Mitchell,
Yes.
Mr. Smith,
Yes.
Mr. Verducci,
Yes.
Ms. Krupp.
Yes.
Okay. So, thank you. That one passes. That was easy relative to the one I'm going to go back to. Members and everybody listening, I need to apologize to everybody on the, oh boy, on the HSA HRA funding by dependent. I believe I miscounted on that first motion. The first motion, as you will recall, which I said failed, was to adopt number 3, a single amount per employee regardless of tier. I'm going to restate what I recorded in case I misheard it. Vice Chair Fox voted yes. Mr. Bailey voted no. Ms. Urban voted yes. Ms. Mitchell voted yes. Mr. Smith voted yes. Mr. Verducci voted no. And Ms. Krupp voted no. So by that count, 1, 2, 3, 4 members voted yes, and 3 members voted no, with the chair abstaining. So that motion actually, the first motion for option 3 actually did pass. So I wanted to let you all know that that was actually the sense of the board based on the first motion made, and that is going to be the recommendation to PEB staff. And I sincerely apologize that I'm a budget person who apparently can't count. So we made it through, I think, agenda item 10. Agenda item 11 is the second public comment period. And so I will turn it over to PEB staff for public comment.
Thank you, Ms. Chair. So again, this is public comment timeframe. I'm going to go ahead and display the number on my screen, and then I'll be calling out the last 3 digits of your phone. And then I'll be announcing that your phone is unmuted, at which time you'll hear the Zoom automated audible saying unmuted, which you can proceed with your comment at that time. The first number that I have here ends in 920, starting with the area code of 404. Your line is unmuted. Okay, the next that I have is 511. Your line is unmuted. The next one that I have is 688. Your line is unmuted. The next one that I have is 755. Your line is unmuted.
And good afternoon. This is Marlene Lockard, Lockard, representing the retired public employees of Nevada. I thought it might be helpful to just add a little bit of context surrounding the discussion of excess reserves. This really initiated after the 2011 major revamping of PEB plans and benefit cuts due to the budget situation at that time. Thereafter, early retirees were removed from the program. The Medicare retirees were shifted to the exchange. And so then that left a tremendous amount of money. It was a tremendous cost-saving measure. Thereafter, each year, then Executive Director Jim Wells would report on the excess reserves and deliver to the board a series of options and clearly marking which options would be a one-time only benefit increase, alerting everyone that it could go away the next budget year. So that began a series of clawing back some of the benefits that had been removed from the 2011 session. And we were talking reserves at that time in double-digit millions. I think one was even as high as 32 million. And so it was clear over a period of time that the 2011 budget cuts, benefit cuts, were too much. So slowly, those recommendations to add benefits back could be sustained year after year until finally they were put back into the base budget. So now that has been done. So that's why you see reserves not accumulating the amount that they had in the past. And so I don't think on an ongoing basis that we're going to have the years of huge double-digit millions of dollars in excess reserves. And for the record, almost all the benefits that had been cut have been reinstated, with the exception of life insurance for retirees and a couple of other items. So hopefully this was helpful, and I appreciate the opportunity to comment. Thank you very much.
Okay, the next line that I have ends in 111. Your line is now unmuted.
Hi, yes, this is Sean Franklin Sewell. For the record, SHAUN. Last name Franklin, FRANKLIN SEWELL. I'm very disappointed in the board for choosing to penalize people with dependents by choosing option 3 on the policy changes. Item number 10, HSA, HRA funding by dependent count. Because you changed the tier, because you changed the way that you're weighting the tiers, you are doubly penalizing people with dependents. So that's all I'll say right now, and I hope that you reconsider that decision as you're moving towards making better policies for the organization. Thank you.
The last one that I have, the number ends in 404. Your line is unmuted.
Good afternoon, everyone. This is Kevin Rampt, RANFT, for the record, representing AFSCME Local 4041, active state employees. Again, I want to thank the entire board and the chair and Laura, Rich, in regards to, and her staff, just as a whole. This is a very difficult time. Policies can turn out to be good, and they could have unintended consequences. So with that being said, this board has in the past has brought forward different changes to policies, and I just hope that these things are open to be able to correct any unintended consequences on item number 10. Again, appreciate your time and support, and we look forward as a organization and advocates on behalf of our members to be able to come to this meeting and continue to have pre-meetings to be able to adjust some of the things that may have been voted on today. We appreciate your hard work. And again, we look forward to being a partnership with PEB. Thank you very much.
Madam Chair, that was all the public speakers available.
Okay, thank you very much. So that takes care of the agenda for today. And with that, it is 1:37 p.m. and we are adjourned. Thank you, board members, for your participation. Thank you, staff and vendors. Have a good day, everybody.
Thank you.